Can I start? Very good morning. Thank you for having me here. It's always a pleasure to be a part of Cardiodiabetic Society conference. This is the 6th conference in succession, and every day, every time we are improving. So I'm very happy to be here and make my presentation. So my presentation is on diabetes and its effect on outcome and survival after CABG. Diabetes affects people all over the world. It's rising as an epidemic. So around 533, can you please put it full screen on my computer? Yeah. So around 531 million adults world over are diabetic, around 10.5% of global population.
You can have only the presenter view in this one.
Okay.
It won't display there.
Yeah, okay. And more people are expected to become diabetic in the coming years. So it is rising at an alarming rate. And unfortunately, the data I'm showing you is all that people have gathered through various consensus and studies. Actually, there are many people who are diabetic and are not even aware, or have not gone or been studied or have been evaluated. So actually, data must be more than what is reported all over. By 2030, we are expecting a further rise in diabetes, and especially in underdeveloped countries, developing countries, because there is less awareness about diabetes and all this. So the number as rising at an alarming rate. As per Indian data, ICMR has shown that around 10.5 crore people in India are having diabetes, and these are reported data. So many must have not even gone to the doctor and may not be aware. So this is expected to rise further by 2045, and that is why government and medical fraternity needs to create more awareness so that people can come for a preventive checkup and prevent the complications. So there is a steep rise in numbers. As you can see, there were 32 million in the year 2000, and then there was 74 million in 2021, and now 101 million in 2025. So you can see the rate of diagnosis and the number is increasing very alarmingly. In addition, there are around 25 million people who are pre-diabetic, and that again is a reported data. Many people may be having diabetes or are in pre-diabetic stage but have not been evaluated, not gone for a preventive checkup, so we are not aware. So more than half of the diabetics are those who are not aware that they have diabetes. I have to change, please someone help me. This is not working. Where do I change from here? Okay. So the prevalence is higher in age group of 74. So we know because by that age, most of the people develop diabetes. Actually, diabetes is usually diagnosed in mid-age, around 40, 45 years of age, when people come with their symptoms, those who are aware. But by the age of 74, you will see many patients coming to our OPDs and coming for surgeries who are diabetics. The incidence is higher in urban population compared to rural population. That may be because of lifestyle and because of the rich fast food they are eating and lack of exercise and sedentary lifestyle and too much of stress. Whereas in rural population, because people are working more of a menial job and are hardcore laborers like farmers, so the incidence is less. But now, gradually, diabetes is also spreading in rural areas, and people who are from low socioeconomic strata also are reporting with diabetes. And also the number is expected to increase further because of further lifestyle changes, because people are just eating on the go. They are not spending adequate time on proper nutrition and diet, on sleep, on stress management. So the number is expected to increase further. Fortunately, because diabetes is a lifestyle disease, many lifestyle modifications can help. But that needs awareness, that needs people to come forward and get themselves evaluated. So it is important all over globally that people should be, more awareness should be created about the dietary habits, about lifestyle changes, importance of stress, importance of sleep for people to have a healthier lifestyle and prevent complications. Most of the time in hospitals like Aiims Rishikesh, which are teaching hospitals, tertiary care, people come to us with complications when they've developed a gangrene or they've developed renal dysfunction, come for dialysis or come for a surgery. Then at that time, recently I operated on a patient who's around 68 years of age. He came for a valvular heart disease, very sick patient, but during evaluation we found he was a diabetic, and that too uncontrolled diabetic. So he said he was not even aware. So that needs to be created. You cannot just assume that because patient does not have a coronary artery disease, so he doesn't need to be evaluated for diabetes. And most of the people who undergo CABG, around 70% of those are diabetics. We know around 70% of diabetics who are uncontrolled will develop renal dysfunction at some point of time and may come to you with a need for dialysis. Now, perioperative and early outcomes in cases of diabetes. So, if you see that increasing complications such as wound healing, most of the diabetics post-surgery will have serious discharge from their wound. If it is not controlled well, then wound dehiscence may occur. Many cases reported of sternal dehiscence have occurred. Fortunately, in our department, we don't have. Our results are very good, and I credit my nurses for that because they maintain strict asepsis. So we've not undergone, but yes, when I was a student at KEM, I have seen patients of sternal dehiscence and delayed wound healing or delayed wound healing. So it is very important that the physician, the surgeon treating, as well as patient's family, both are aware that if diabetes is not controlled, it will lead to renal dysfunction, wound dehiscence, stroke. It may lead to gastric paresis. Many chronic diabetes who have neuropathy have gastric paresis. Once in Medanta, I was a senior consultant there. There was a patient who was expected to get discharged next day morning. And the patient's son was a state bank manager in Dehradun. So because I'm from Dehradun, we started talking, and he was very happy and was thanking everyone profusely. The patient was in the ward and in the room, his deluxe room, and patient was given a meal by the nurse, and patient was constantly telling that I'm feeling very full, but the nurse was in a hurry and she wanted to give her insulin dose and give the meal, so she went away. The patient had meal, and around 9:30, quarter to 10, patient aspirated. He had a regurg and he aspirated. So many chronic diabetic patients, especially elderly, develop gastric paresis, which goes undiagnosed because patient himself or patient's family will keep doing home remedies and don't realize that all the acid reflux, all the rigors they are having is because the food is lying stagnant in the intestine, not getting absorbed, not moving further, and can lead to serious complications. So if you see latest diabetic medications like semaglutide and SGLT2 inhibitors, all those which are being talked. So now the instructions are also to stop them 2 to 3 days prior to surgery so that the effect of gastric paresis is not so profound, because during anesthesia and intubation, the patient may aspirate and may prove to be fatal. So, again, if the patient has all these complications, patients will have a delayed discharge, which will cost more to the patient, as well as will increase hospital expenditure. How? Because your beds will remain occupied and new patients cannot be admitted. So it's a problem for the administration, the bed management. It is a problem for the patient family because the financial stress is on them. And patient himself doesn't feel well. So if there's delayed ICU stay, delayed discharge, that causes a lot of stress and expenditure both to the hospital as well as to the patient. And also there is higher mortality in patients or diabetic patients compared to non-diabetics. Long-term survival of diabetics also is less as compared to non-diabetics. So when a patient comes for surgery, supposing during surgery, all through during surgery, you've maintained a very stringent control of sugar, and you feel, while in hospital ICU charts, I was seeing that fasting sugar was 110, and during surgery also, if you see the chart, it was well managed. But the patient preoperatively had a deranged function and HbA1c was higher. Patient had diabetes also for a longer time, means longer than 10 years. So in all these patients, you will see the outcome being poorer. And many a time patient will complain that in the same hospital, one non-diabetic patient will go home without any symptoms, will have a longer survival, other patient may not have that survival, and they blame the hospital and administration. But it is not because of the surgeon's lack of skill, it is because diabetics usually fare less, the surgery favors less to diabetics as compared to non-diabetics. So if you see the mortality, in 7 years, there is a very high mortality in diabetic patients, means those who have undergone CABG. I'm talking right now of patients who have undergone coronary artery bypass surgery. So at the end of 7 years, 52% mortality is expected. If you compare the 10-year survival, so it is 63% in a diabetic compared to a non-diabetic patient who has 81% survival. This is all global data taken from different various randomized controlled trials all over the world. At the end of 20 years, again, the diabetics, 20% will have a good result, whereas 32% non-diabetic patient will survive after CABG. We are talking of only CABG, which is an isolated comorbidity. We are negating other factors, contributing factors. So overall, all-cause morbidity and mortality in diabetic is much higher as compared to non-diabetics, and they also have a need for redo procedures. Why? Because diabetes affects the microvasculature, so patient will develop new lesions. Although the graft may be patent, but patient will develop. And because South Asia and Indian population is deficient in vitamin D, if we get all our tests done, so we'll find most of us are deficient in vitamin B12 and vitamin D. So in the presence of low vitamin D and high sugar, patient's microvasculature gets affected, the plaques also can get dislodged, and patient can develop new lesions. So there are more redo procedures if a patient is diabetic as compared to a non-diabetic patient. And there is increasing hospitalization also for various reasons in diabetics as compared to non-diabetics. And the progression of disease is faster in diabetics. The atherosclerosis progresses faster as compared to a non-diabetic. So what are the factors contributing to low survival? One is diffuse lesion. The moment a cardiologist or a cardiac surgeon sees a coronary angio, we immediately say this patient is a diabetic. These are diabetic coronaries. So diabetic coronary is a separate entity where the disease lesion will be diffuse. It affects the distal most vessels, so it becomes like a thread. There is a poor distal runoff, and many of the lesions at times are not even amenable to bypass, because when we open and do the bypass, the internal diameter is less than 1 millimeter, or it is 1.25 millimeters. So how can you expect the graft to be patent, especially if the patient does not have a stringent control post-operatively? If the patient is not very serious about sugar control, so the grafts may block and patient may come for redo surgeries. The lesion is already diffuse. These are long lesions because it affects all over the vasculature. And the endothelial dysfunction is more marked in diabetics. They also have other comorbidities. As I told you, 70% of diabetics will have renal dysfunction. They are elderly. They have poor immunity. They have overall peripheral vascular disease. So all these things also affect a patient's survival. Now, HbA1c levels. If a patient preoperatively had a HbA1c of 7 or less, the patient will fare better. For example, if the patient was pre-diabetic or a patient had really controlled well through diet. But most of the patients who have HbA1c above 7.5 will have again various complications. So that HbA1c level is also a very good indicator. Pre-operatively, the surgeon would know how would the patient fare. Now, question arises, if the patient has HbA1c higher, what should you do? So ideally, you should postpone surgery and advise patient to get the HbA1c controlled. But most of the time, it doesn't happen and the patient faces poorer outcome. Insulin-dependent diabetics, we all know, have a poorer outcome. And for each percentage increase in HbA1c, mortality increases to about 13%. Means from 8 to 9, if the patient moves, the mortality also increases 13% every time. Strategies to manage, to have good control is have a good history. Ask the patient for how many years the patient is having symptoms. If the person is educated, he or she may know for how many years the patient is having diabetes. If the person does not know, you can ask the symptoms about weight loss, increased thirst, increased urination, or if the patient has been hospitalized for any wound infection and such things. Pre-operatively surgery, you should assess the HbA1c level. If the patient is elective, you can postpone and first control sugar, then take the patient for surgery. And then if the person is uncontrolled on oral hypoglycemics, the patient should be shifted to insulin. Again, oral hypoglycemics have their own side effects, like metformin will have lactoacidosis in case of renal dysfunction, sulfonylureas will have a risk of hypoglycemia, SGLT2 will have a euglycemic ketoacidosis, GLP agonists will have gastric emptying delay and may have aspiration at the time of intubation on table. Similarly, medications should be stopped adequately before surgery, at least 1 or 2 days prior, and if you are taking a semaglutide injection, it should be taken at least 5 days before surgery. It should not be taken just 1 day prior to surgery. If the dose is coming, it should be postponed so that the effect is not profound. For elective surgery, you can stop them 2 to 3 days prior, like empagliflozin, and other medicines which are safer should be continued for at least 24 hours, but before 24 hours should be immediately stopped. Insulin management is the best way to manage patients intraoperatively. IV insulin is the best way to manage. Subcutaneous insulin will not work in a cardiac surgery where the patient has hypothermia, so the absorption in from subcutaneous tissue will be affected. So IV insulin is the best form where sugar can be managed for every 1 to 2 hours. You can check the sugar and accordingly titrate the dose of insulin. Intraoperatively, you should have careful monitoring, so at least 2 hourly you should have a sugar management, and frequent sugar management should be balanced. The random sugar, if it is 180, IV infusion can be stopped. At any time, the random sugar should be 140 to 150. Post-operatively, in ICU, the patient should continue on IV antibiotics, but when patient comes to step down ICU or HDU, you can shift to subcutaneous insulin and see how the patient's sugar chart is. Before discharge, usually most of the patients who are on oral hypoglycemic, we discharge them on oral hypoglycemics, but they are given proper dietary counseling and diabetic medication counseling, so that the patient has a regular follow-up, maintains a sugar chart at home also, and we teach them how to use a glucometer and why it is important to take medication on time. Post-operative nutrition is also very important. Most of the diabetics should take low diabetic and low sugar carbohydrate diet, but many of them are not aware and continue taking high fat or high carbohydrate meal that may again shoot the sugar up and may create population. So awareness is very important so that patient doesn't develop sudden hypoglycemia, especially if you're sending the patient on subcutaneous insulin. For a successful long-term outcome, it is important that there's interdisciplinary care. The surgeon should not try to do everything himself or herself. Take help of endocrine team, take help of a good nutritionist, a good physiotherapist, advise the patient about being mobile. The more the person moves, the more muscle utilizes the glucose and the better sugar management is. A good proper tailor-made diet chart, according to the patient's dietary habits, can be given, and then patient can be asked for regular follow-ups. And psychological counseling about sleep and stress and lack of, to avoid social media before sleeping so that the patient has adequate rest. There's a diabetic legacy effect. Many people think that their sugar was immediately very good post-surgery, and they say, but we maintained very good sugar post-surgery or in hospital also it was good control. But diabetes legacy effect says the longer duration you have surgery, diabetes before surgery, for example 10 or 15 years, and the higher your sugar was pre-operatively will have its lasting effect. So it doesn't matter how stringently you maintain the sugar in OT, it's important how it was before surgery. That is why
Dr. Namrata,
early diagnosis
please,
it's
summarize
just,
your talk
yeah.
so that.
So the CABG recently has shown to have equal benefits in Syntax trial that as compared to PTCA. So diabetes is not a contraindication to surgery, and in conclusion, it is a disease which can be managed if it is diagnosed early, preventive health checkup and proper sugar management. You can have a successful surgery and patient can have a longer life provided they are aware, are given education and have a regular follow-up. Interdisciplinary care always helps. There are some areas that need focus, that how much target sugar a surgeon should manage. I personally feel don't have a very stringent control, have a moderate control of sugar, avoid hypoglycemia which can be dangerous, the patient may fall at home. Interdisciplinary care with good dietary counseling, tailor-made, and stress management can help the patient with deep breathing and yoga and all these exercises to get better. Thank you.
Thank you so much for a wonderful talk. I think the idea is the diabetics, if they are controlled and HbA1c is well below 7, they fare good. I mean, their outcome is relatively much better as compared to those who are. So it gives an opportunity to have a better and, a fair control of blood sugar prior to taking these patients for surgery. I think as physician or diabetologist and endocrinologist, we must all emphasize to the patient that there is no hurry for surgery, but if you control your HbA1c, that outcome is going to be better. Just one addition from my side, I think those patients who happens to be diabetic and hypertensive at the same time, which of course coexists to a larger chunk of diabetic population, just changing antihypertensive from any antihypertensive to metoprolol makes a difference. So the perioperative outcome are much better to those patients who have been shifted on beta blockers for many reasons. So for example, dysautonomia is there in diabetic patients, this is well taken care. And if you look at the mortality data after the CABG and other trials, you will find that the patients who are managed on beta blockers, they have better outcome as compared to those who have been managed on ACE inhibitors or maybe ARBs or maybe calcium channel blockers. This is from Dr. Dhaneshwar. Any comment from your side?
Excellent comprehensive talk. I want to know what is your post-op management strategies among the diabetic patient, which is differ from non-diabetic patient during OPD follow-up?
In OPD follow-up. So if I have discharged the patient on oral hypoglycemic, I will ask the patient when he comes for next checkup. Normally we have a checkup after 1 week. then after 1 month, then 3 months, 6 months, and then annually. And if a person is diabetic, I ask them to come 6 monthly. So when the patient comes, I ask them to keep a diet chart ready, a sugar chart ready. So in most of my patients, whether they are not, even if they are not very literate, if you guide their family, so how to use a glucometer, they maintain a chart. They come to me with in OPD this thing. Then you can see whether fasting is normal. Some patients have fasting is normal, but postprandial usually is rising and going beyond 250. In that case, we have a review with endocrine, so I have a coordination. I usually send them to the physician to have it optimized. Similarly, some people complain that post-dinner, sometimes they take light dinner and they develop that I was developing trembling and I was feeling cold and clammy. So you realize it may be a hypoglycemic kind of effect. So again, then you have to tailor the diet chart and ask them, inquire them how they are faring. But most of the patient, if they are maintaining their sugar chart, gradually they start understanding that my fasting sugar was more than 140 or 150 and I need to have a better control. Slowly, by the end of 6 months, when they start walking around, so their sugars are much better controlled and their stress of surgery also is gone, because most of the patients get depressed post cardiac surgery. They feel life is gone and I'm not able to fulfill my responsibility. At that time, you have to use your sympathy and compassion and explain to them life goes on, and if he manages well, he or she can lead a better life. I have patients who are now 15 years post CABG and they are doing well. They maintain their sugars well and they are doing well.
Thank you so much, ma'am, for such an insightful session. Now I would like to request our chairpersons to felicitate our speaker, Dr. Namrata Gaur, ma'am. Thank you so much, ma'am. I would also like to request Professor Ravikant sir to felicitate our chairperson, Dr. Daneshwar Meena sir. Thank you so much. Our next session is on a highly relevant topic, ventricular dysfunction in diabetic patients. We are privileged to have Professor Bhanu Duggal ma'am, Professor Head, Department of Cardiology at Aiims Rishikesh as our speaker. I also take the pleasure of welcoming our chairpersons, Dr. Seema Mahant ma'am, Associate Professor, Department of Medicine, Aiims Bhopal, Dr. Mukesh Bairwa sir, Additional Professor, Department of Medicine, Aiims Rishikesh, and Dr. Kapil Sharma sir, Associate Professor, Department of Medicine, Aiims Bilaspur.
So good morning, everyone. So I was just seeing the audience. These are our mainly residents from medicine, right? Okay. Thanks, Dr. Ravikant, for having me here. And I wanted to I chose this topic because I thought our residents should be very, very aware of this condition. So I would like to first, my question is, what do you know about cardiovascular disease and diabetes? We will not look at any slides just now. One of you can just answer, what do you know about when you have a diabetic patient, and when do you think that he has some cardiac problem? When do you suspect? Anyone can answer. Any answers? Anything? Do you suspect he has a cardiac disease when he has chest pain? You can at least raise your hands. When do you think you have a diabetic patient, he's coming to you, you are writing your oral hypoglycemic agents, metformin, sulfonylureas, whatever, and he's coming to you he's 40 years of age, he comes to you at the age of 41, 42, 43, HbA1c is good, it is 7, nothing to do, he has no chest pain, he has no blood pressure, and you say, nahi, sab theek hai. Anything, any insight? Because how do we interact then? Then I'll just read my slides and go, what is the point? Someone has to get up. Yeah. You have this mic? Idhar aa jao, aage aa jao.
the process has already started at which his cardiovascular risk has increased. There is cardiac remodeling happening, there is vascular remodeling happening. So it can either lead to dysfunction in the form of difficulty in relaxation of the myocardium, or later on it can lead to a systolic dysfunction of the myocardium.
So how do you screen him?
Ideally, if the patient doesn't have symptoms or signs, we can go for a pro-BNP or anti-pro-BNP level at that time. Or
So,
at the
yeah, so
baseline,
you
we should
have
at least
good
get an
answers.
ECG.
So onset of LV dysfunction can occur, you can sit here, yeah, can occur in a very early stage in diabetes. So the problem is when the patients are sent to us, they usually are in the late stage with atherosclerotic disease. And the atherosclerotic disease in diabetes is already very advanced. If we look at the angiograms, it is usually a triple vessel disease. It is very, very advanced, and as Dr. Namrata said, if it is diabetes with triple vessel disease with LV dysfunction, we send them for bypass. The other problem which we face is in intervention. So after PTCA, most of these patients are more prone to having in-stent restenosis or stent thrombosis. ISR, in-stent restenosis, is very common in these patients. So you have two sets of patients who come with atherosclerotic cardiovascular disease or coronary artery disease. For them, you can do a risk scoring. That is by, what is the score used for CVD for diabetes? Any idea? So, okay, so let's start with the slides. And the second, I'll be covering ventricular dysfunction, as Bala said. I'll be covering ventricular dysfunction, which is not related to CAD, which is not related to hypertension, which is commonly known as diabetic cardiomyopathy. And for that, early screening should be done. So diabetic cardiomyopathy is myocardial dysfunction in diabetics independent of other cardiac risk factors, that is CAD, hypertension, or severe valvular disease, and is basically caused by abnormal glucose metabolism resulting in structural heart defects and dysfunction. Hallmarks of this is, so in echocardiography, what happens is you send the patient for echo and we write normal LV function. So what you specifically have to ask for abnormal diastolic dysfunction. Okay, so you people know how diastolic dysfunction is detected. You had a workshop on that. So what are the markers of early diastolic dysfunction in a patient with normal LV systolic function? These are all coronary artery disease, high risk. Okay, so what are the markers of diastolic dysfunction in a patient with normal left ventricular function, and when do they appear? So one is the Doppler. Yeah, you can speak, right?
The one is the Doppler, as you mentioned, ma'am, the E by A we can see on the flow Doppler. The other one is the tissue Doppler index. We can see the E prime at the septal and the lateral wall. And we can also measure the LA volume index. That would also be an indicator of.
Very good. So you've told E. So E by E prime, that is tissue Doppler. E by E prime more than 15 is a marker of severe coronary artery disease. These are the how LV dysfunction takes place. That is hyperglycemia causing hyperinsulinemia and insulin resistance, leading to decreased cardiac glucose utilization and increased lipid utilization by the cardiac myocardium, which leads to cardiomyocyte apoptosis, increased fibrosis, leading to delayed relaxation and early diastolic dysfunction. So we measure E by E prime as a detector of early diastolic dysfunction. However, it is not possible to send patients for echo in every year or every 6 months unless you are trained to do all these parameters. So there's another non-invasive marker of LV function. What is that? What is the biochemical marker of early ventricular function? So NT-proBNP, it has been found out that it can be a screening marker in patients who have high HbA1c of more than 8. The first stage of dilated DCM is clinically asymptomatic because of increased fibrosis and stiffening. There is reduction of early diastolic filling, increased in atrial filling and enlargement, and elevated LV end diastolic pressures. So even if the patient has a normal coronary angiogram, ask the cardiologist to just go into the left ventricle and give you the end diastolic pressure. And that will show that the patient's early stiffness has started. Diastolic dysfunction, left ventricular hypertrophy is the earliest. Even before early diastolic dysfunction, what happens is LV hypertrophy occurs. So the mass of the left ventricle will increase. And the best way to measure mass is cardiac MRI. But obviously you cannot go and start doing cardiac MRIs in the patients. So by echocardiography, there are certain ways to measure early, that is before your by E prime, you can even measure the diastolic dysfunction very, very early, especially in a patient who's been on diabetic treatment for the last 1 to 2 years. You can ask them to undergo an LV mass evaluation. So LV mass can be measured by measuring the septal thickness, the posterior wall thickness, and there's a formula in which you feed it, and it uses this formula and gives you the left ventricular mass. The other finding is cardiac MRI. In cardiac MRI, one is by echo, one is LV mass, the other is, it tells you the amount of fibrosis by gadolinium enhancement. So the LV mass is the earliest stage. The earlier you pick up, the earlier you will start the treatment. And the first treatment is, I'll come to that, so we've already spoken about it. Cardiac MRI can be used for LV mass quantification and fibrosis. And on echo, it can be used, LV mass can be measured. The other thing to measure on echo before tissue Doppler is global strain imaging. So global strain imaging can be measured. There are 3 types of global strain. One is longitudinal strain, the other is radial strain, third is circumferential strain. So the only method of which is standardized for LV function and before tissue Doppler is global strain imaging, and LV longitudinal strain is the most important way of picking up early left ventricular function. LV hypertrophy is the first feature of dilated cardiomyopathy by autopsy. There is concentric adverse remodeling, and some degrees of LVH can be present even in the pre-diabetic stage. So pre-diabetic stage means impaired glucose tolerance. So cardiac dysfunction starts at the stage of impaired glucose tolerance. So it can be so early. And impaired glucose tolerance correlates very well with relative wall thickness and LV mass by height ratio. It has prognostic significance and can be reversible in the very, very early stage, at the stage of impaired glucose tolerance. And if you at that time start managing diabetes by lifestyle, it is reversible. So the patient also, you have to convince the patient, right? Just a blood glucose, he says, nahi, mera HbA1c to abhi 5.8 hai, maine 6 cross nahi kiya. So these are factors which actually, if he is developing this, he has a strong family history, cardiac dysfunction has started, you can convince him to have lifestyle changes and very early optimal glycemic control. At that stage, this fibrosis, early fibrosis can be reversible. So this was the trial diastolic heart failure study and included, so you see the 3 groups of patients. You have pre-diabetic, you have diabetic, and you have diabetic subgroups. The insulin, patients on OHA and insulin treatment. And they found that along the entire continuum, it's not the pre-diabetic mein nahi hota hai, HbA1c correlates with E by E prime ratio. And even the 6-minute walk test, it decreased along the diabetic spectrum. So 6-minute walk test is a very good marker of diastolic dysfunction and it's such a simple test and it has prognostic significance. And it correlated with E by E prime and grade of diastolic dysfunction. The other study is a large observational study which had 1760 diabetic patients, and as we discussed, E by E prime ratio more than 15. Actually, when you reach this E by E prime ratio, your disease is very, very far advanced. So you don't wait for it to go up to E by E prime. So better to do longitudinal strain in these patients, which is a very early marker of LV diastolic dysfunction. Coming to late stages of LV diastolic dysfunction, we have discussed patients with type 1 diabetes who develop, mainly what is happening now, patients are coming to us in congestive heart failure, and that time when we do the echo, we say E by E prime is 15, or patient has, and they have preserved ejection fraction, and then also we are wondering whether patient has cardiac problem because his systolic function, his ejection fraction is 60%. So you keep wondering whether I should treat him as heart failure or not as heart failure. And there are distinct mechanisms in type 1 and type 2 diabetes. Type 2 diabetes is insulin resistance with increased serum insulin. And the GLUT4 translocation is the basic mechanism in when early insulin resistance is blunted and leads to impaired glucose uptake in the cardiac myocardium. These are the mechanisms. I'm sure you know them better than me. So global longitudinal strain. 30% of patients with diabetes have abnormal systolic strain. Though we call it systolic strain, what happens is you measure the length of the myocardial fiber in both the phases. And it tells you, it is a very early sign and correlates with the appearance of fibrosis, early fibrosis. And the moment you get it, you should start label the patient as having cardiac dysfunction. Myocardial performance index, which reflects both diastolic and systolic functions, is also altered in the pre-diabetic stage. GLS is independently associated with NT-proBNP, cardiovascular events, all-cause death, and hospitalization, not LV ejection fraction of 60%, 50%, 30%. Even GLS is correlated with mortality and morbidity. So echo and cardiac MR, in both there's no radiation exposure. There's wide availability of echo. So even though cardiac MR picks up fibrosis very early, it is not available. It's an expensive test. It is very expensive. It is not widely available. And echo can pick up LV, LA volume, E by E prime ratios. Another thing I wanted to highlight here is that right ventricular function also has to be studied. So RV diastolic dysfunction, RV tricuspid valve can be told by RV tricuspid valve annular motion, and that should also be measured. It may appear earlier than the LV dysfunction. So RV dysfunction also, you should study the annular displacement of the tricuspid valve, is a very early marker of cardiovascular disease or in diabetes. This is the mechanism, activated RAS, oxidative stress, and autonomic neuropathy, all leading to cardiac stiffness, hypertrophy, and fibrosis, diastolic dysfunction, and systolic dysfunction when we get patients is very late. Coming to the diagnostic tests, again, this is again when we speak of heart failure. It is recommended to measure BNP, 12-lead ECG is recommended, transthoracic echo, chest X-ray, and therapeutic approaches is of course glycemic control. Management of cardiovascular disease and type 2 diabetes, the main agents which have been found to be very useful are the SGLT2 inhibitors. They have class 1 recommendation for reducing cardiovascular risk, heart failure, hospitalization, and renal failure. Metformin also has beneficial effects, and it improves the myocardial energy metabolism, and in early stages can reverse cardiomyopathy if it is used to reverse cardiovascular dysfunction. So SGLT2 inhibitors, EMPA, are all recommended in patients with type 2 diabetes with multiple ASCVDs. Summary of the glucose lowering therapies, class 1 is SGLT2 inhibitors, DAPA, EMPA, and SOTA in heart failure, reduced ejection fraction. but in preserved ejection fraction and borderline ejection fraction of 40 to 45, DAPA and EMPA have been shown to have a very good effect. And if the patient has the other thing I wanted to also, by these two talks, you may be thinking that, okay, keep the HbA1c optimal. Keeping the HbA1c around 7 is optimal, because if it is lower, if you want a very tight control, actually it was found to lead to increased mortality. And depending upon the glycemic targets, the glucose must be maintained at a particular level. Very tight targets, too many episodes of hypoglycemia are also related with increased cardiovascular mortality. Management is SGLT2 inhibitors. 5 drugs help: sacubitril valsartan, MRAs, and ARBs in case patients cannot tolerate ACE inhibitors or valsartan. Diuretics are recommended. MRAs are class 1 choice. Ivabraden should be used to decrease the heart rate in case patient is not able to in case we are not able to control the heart rate less than 70 with beta blockers, we can shift and add our Ivabradens. Digoxin is a very useful drug and should be, in case all the 4 drugs fail, we add digoxin, and it has been found to be useful even to decrease mortality in patients with LV systolic dysfunction. Gene therapy is a novel therapy which is coming up, basically targeting the mitochondrial heat shock protein, that is MTHSP70, mitigates mitochondrial proteome disruption, inflammation and fibrosis in the diabetic heart. And this is one MCQ of which you should be aware, because it is showing a lot of promise down the line. And non-coding RNA MIR146A mediates inflammatory changes and fibrotic damages, and anti-non-coding RNA therapies are being designed. Thank you.
Thank you, Dr. Banu, for such a wonderful and interactive talk. I think glycemic control is important to prevent the cardiovascular disease, but body weight is also important. Maintained body weight is equally important as the HbA1c. And second thing, use of beta blocker, as Professor Ravikant sir said, use of beta blocker give very good outcome. And we forget the most important drug, digoxin. आजकल मैंने देखा PG students, they are not using digoxin. Such a wonderful drug. We should use in digoxin in multiple
Only thing, beta blockers, sometimes patients don't tolerate. They have postural hypotension, they have, they have the symptoms, postural symptoms. So if we really, we can add on Ivabradin in that condition.
But beta blocker, if the patient is on beta blocker, the patient have very good outcome.
Yeah.
They have very reduced the
Only if they
morbidity.
don't tolerate. Otherwise, beta blockers are very good. Yeah.
Ma'am, old thought we think that beta blocker is not prescribed in diabetic patient because of hypoglycemic unawareness. But the beta blocker is a very good drug for a heart failure patient. Ma'am, I want to one question, that what time we have to suspect and when we have to send the patient for screening of echocardiography in type 1 and type 2 diabetic?
Very good question, because honestly, I was looking if there are any guidelines. So yes, Australian guidelines have now, they are the American and the European guidelines have not said about routine screening, but Australian guidelines and New Zealand guidelines are saying that you should do a routine baseline echocardiogram, and then you should do a regular, no one has said annual or this thing, but they have recommended early echocardiogram to detect early dysfunction, and routine, and they have said repeated screening. But timeline of 6 months and 1 year is still not there. But they have said you must screen the patients initially, and especially patients in whom HbA1c is uncontrolled, in who have very poor sugar control levels, who have a very strong family history. These are the patients in whom screening should start very early. even in a pre-diabetic patient, if he has a strong family history and you think that he's likely to have diabetes and has uncontrolled sugars, you send him for a cardiac screening.
Any question from the audience?
Although this is not a recommendation, but this is what is being practiced by endocrinologists and largely by diabetologists across India. Any diabetic patient who is having more than 10 years of diabetes duration, even at the first visit, must be subjected to echocardiography. Uncontrolled hyperglycemia for a pretty long time warrants echocardiographic evaluation, at least a dysfunction. We also have many studies from within Aiims Rishikesh also, where we have found even asymptomatic patients having anti-pro-BNP. Anushka is doing the research. And we are surprised to see that these patients, absolutely healthy patients, diabetic, they have high anti-pro-BNP, 3-4 times higher.
Yeah.
So probably the first OPD visit is the right time to screen all of them. That should remain one of the important pillars for diabetes management or the comprehensive management of a diabetic patient in your outpatient clinics. And also, you have to ask if they fall in any of the high-risk category, quasi relative having premature coronary artery disease or fitting into high risk or extremely high risk. I kindly screen them in the first visit or second visit itself. I think that is the way forward.
So, so I came across a study in which what they are saying is BNP correlates with cardiac dysfunction, early diastolic dysfunction, especially in patients with HbA1c more than 8. With very well controlled, they've not found a correlation, but with HbA1c of 8 and more, they found a good correlation.
You were saying that you have come across a study. We have cutoffs for the heart failure. This study, or are there any this recommendation for the level for which on which we can suspect that patient having this earlier diastolic dysfunction, because every patient will not be able to undergo that tissue Doppler or this.
So for pro-BNP, in this study of HbA1c8, they said 46. I think 46 picogram per. My residents can. What is the? Yeah, so there are two studies I found. In one was 25, and one has found HbA1c8. It is 46, right?
If anti-pro-BNP level are more than 125 picogram per ml, it is supposed to be found in our study we are taking.
Yeah, and one very powerful indicator, non-invasive, triglyceride to glucose ratio. It's a very powerful ratio, non-invasive. The moment you do it and calculate, you are 90% surety, Bala. We have the predictability of almost 96 to 98%. If you look at the ROC, this is almost fitting in the ideal ROC for predicting early heart failure by just simple TGY, triglyceride to glucose.
Oh, okay. That's a very good addition. Okay.
Thank you, ma'am. I think we have to conclude the session. Thank you.
Thank you so much, ma'am, for that insightful session. May I request our chairpersons to kindly felicitate our esteemed speaker, Professor Dr. Bhanu Duggal, ma'am. May I request Dr. Prakash sir to kindly felicitate our chairperson, Dr. Kapil Sharma sir and Dr. Seema Mahant ma'am. Next, we have Next, we have Nuclear Imaging in Diabetics by Dr. Vandana Ma'am, Additional Professor, Department of Nuclear Medicine, Aiims Rishikesh, a session that explores diagnostic innovation in metabolic disorders. Chairing this session, we have Dr. Arvind Sir, Senior Physician from Kashipur, Professor Surekha Ma'am, Department of Community and Family Medicine, Aiims Rishikesh, and Dr. Akhilesh Sir, Assistant Professor, Department of Medicine, Aiims Rishikesh. Please join me in welcoming Dr. Vandana Ma'am.
A very good morning to the respected chairpersons, and I thank and congratulate Department of Medicine of Aiims Rishikesh to organize this scientific feast. Especially congratulations to Dr. Ravikant, Head of Department of Medicine, who is a good friend, colleague, and a very enterprising physician. So if the chair permits, may I start my talk? Thank you. So we all know all these statistics. So diabetes mellitus is right now a big pandemic, has been over the last many years, and it's a very big problem in India. As we all know, India is, I think, having the highest burden of diabetic patients in the present times. And this has only been increasing as the world trends show that the number of patients are increasing, the management strategies are improving, so we have more life expectancy and we need to improve the quality of life. So all our treatment strategies are aimed towards that. So coming to nuclear medicine, basically nuclear medicine involves imaging using radioisotopes. So since we have a mixed crowd of non-nuclear medicine people majorly, so I'd like to introduce you to what exactly happens in nuclear medicine. So we basically have imaging procedures which involve two steps. The first one is we inject a radioactive isotope, which is called a radiopharmaceutical, into the patient. It is administered either intravenously or orally or by inhalation. So intravenous is the most common route. After that, once this tracer is in the body, there is a series of images that is taken by the machine called as the gamma camera or the PET-CT machine, which forms the functional images of the patient. And this is how the isotope is produced. We have the isotope generators. We label it with the cold kit, which is like your injection, like an antibiotic injection. It's a lyophilized vial. So the two are combined to form the radiopharmaceutical, which is done in the hot lab or radiopharmacy, which exists in every nuclear medicine department. And then we have the imaging that is in the gamma camera or in the PET-CT machines. So most of the complications of diabetes, as we all know, begin with functional alterations before the structural changes occur. So that is like neuropathy or microvascular disease, etc. And these affect various systems of our body. So what PET or scintigraphy does is that it is able to visualize these changes much before the structural changes have taken place. So we have the GI, we have the nephropathy, we have the cardiac involvement, we have the peripheral vascular complications, and we also have metabolic alterations. So what are the major systems where diabetes is affecting, and where all the role of nuclear medicine can be potentially seen is the cardiac system, about which we had a very nice detailed talk just now. We have the GI system. In cardiac, we have the silent ischemia, the autonomic neuropathy, and the diabetic cardiomyopathy. In GI, there is autonomic neuropathy leading to various gastric and bowel motility changes, majorly, which are very difficult and very, distressing to the patients. Then we have the renal system where, of course, the hyperfiltration, albuminuria, etc. cause nephropathy, which we all are aware about. Then there is the peripheral vasculature, which leads to bone and peripheral vascular diseases, which lead to bone and cellulitis and even soft tissue diseases in the foot, and which is the diabetic foot. And then we have the metabolic alterations, metabolic system, where altered glucose utilization can be seen with beta cell imaging. So what are the spectrum that we have is, we will be going into the detail one by one. So we have the PET and PET-CT, the planar scintigraphy, the SPECT-CT, and all these modalities for the various functions. So hybrid imaging refers to SPECT and CT combination. So when we image with the gamma camera or the PET imaging, we combine those images with the CT or the MRI, and that hybrid imaging gives us the functional abnormality and localizes it for us with the structural imaging using the CT. So it is even a better modality. It gives us more information. So what happens in the cardiac disease? Accelerated atherosclerosis leads to coronary artery disease. There is silent ischemia due to autonomic neuropathy. And there is diabetic cardiomyopathy, which is due to the microvascular disease leading to fibrosis and diastolic dysfunction. So we all are quite familiar with the myocardial perfusion imaging. So now this helps us to identify the silent ischemia, because many of these patients may be asymptomatic. And we have the PET studies which allow the absolute quantification of the coronary artery flow, that is the CFR evaluation. So myocardial perfusion studies help us to assess the perfusion defects in the myocardium, left ventricular function, that is the ejection fraction and wall motion, in diabetic patients with coronary artery risk. So here you can see an example of a normal myocardial perfusion scan where we have the upper rows, these are the axial slices of the left ventricle. This is the anterior wall on top, this is the inferior wall, this is the lateral wall, and this is the septum. So as we can see, a normal myocardial perfusion scan on axial will look like a medu vada. So if you see a proper medu vada, then it is a normal myocardial perfusion scan. Then these are the longitudinal images, where in this one you can see the, this is the vertical long axis where you can see the anterior and the inferior wall, and this is the horizontal long axis where you can see the septum and the lateral wall. So in every wall can be seen in two images. Here you can see that, so over here I would like to show that these two rows represent the stress and the rest images. So here again another example is where you can see there is a mild reduction in tracer over here. Okay, this one is not visible, which I am showing. Okay, where is it? I'm sorry. Yeah. Laser pointer. Okay, I'm very sorry. Anyway, that was normal. So here, this one, this here, and the arrow is also showing, is a small defect which you can see in the lateral wall, and that defect is seen improving on the rest images. So this is called as a reversible or a defect which can be reversed on rest. So it is a stress-induced ischemia which we see, and it is a common feature of coronary artery disease. Then if you see a defect which does not fill very well on the rest, that is called as a fixed perfusion defect, and it represents old infarct or something which is permanently caused. So it is there at all times, even at rest and even on stress. So this is what you can appreciate on this image as well. So you see a defect, perfusion defect on the inferolateral wall. Then using the PET coronary flow reserve studies can be done in diabetic patients. So wherever this myocardial perfusion imaging with the SPECT is not very helpful, or it is not very clear, the PET myocardial perfusion with coronary flow reserve has shown to be very, very effective. So a reduced CFR correlates with microvascular dysfunction and worse prognosis, even when sometimes this particular SPECT study may be normal. So this actually causes the quantitation of the flow reserve that the coronaries have, and it improves the risk stratification. So this is an example where you have a patient who was a 61-year-old male with unstable angina, and he had a negative scan on the SPECT MPI, but there was a 70 to 80% disease on
the angiogram, and there was a calcium score of 490. He was a diabetic and a hypertensive. So as you can see, the scan overall is quite okay. This particular streak that you see in this image here down, this is called as the diaphragmatic attenuation or the liver uptake activity, which is an artifact. So you can see the circular uptake in all the walls of the myocardium are nicely seen. So there is no absolute defect that you see on the scan. So then the patient underwent a PET imaging with the PET perfusion tracer, where we use N13 ammonia, and then we do a stress with the regadenoson injection, and again the PET imaging is done for perfusion. Now these are the PET images, which again show no major perfusion defect as such, which is nearly expected, but there is a mild ischemic dilatation that is seen. It is up for about 1.25, and everything else seems to be normal. However, when you come to the flow reserve study, in that you see in this table that the flow reserve is around 1.8, 1.8 and 1.8 respectively in most of the territories. So this is an indicator of some flow restriction, flow limiting disease. So a CFR of more than 2 is normal. Anything which is less than 1.7 is abnormal, and absolutely less than 1.7 is absolutely abnormal, but this 1.8 is kind of a borderline situation. So here we can, and especially because it was there in all the 3 territories, it is a kind of a balanced disease, which is very difficult to pick up on imaging. So this quantitation really helps to understand the balanced ischemia, where, because even if it is a lower degree, it is 1.8, but since it is there in all the 3 territories, it causes absolute reduction in the flow of the coronaries, and that is the reason for the patient to be having the symptoms. So the markedly reduced flow reserve globally in all the 3 territories was compatible with severe diffuse disease burden. So this is very significant to pick up these subtle diseases. So the uniqueness of this quantitation with using the CFR, it overcomes the shortcomings of relative imaging with PET and SPECT. So most of the times it is enough to do the imaging with the SPECT or the MPI, but relative imaging is important in certain conditions. And relative imaging assumes that the region with high, what happens in relative is we assume that the one that is normal. We do not have any parameter for absolute quantitation. So that is where the difference comes. So it is having a superior sensitivity for multivessel disease, that is 90% with PET MPI for flow quantification versus 70% with PET MPI, and it is very low with SPECT MPI. So it looks into the entire coronary tree, the focal, diffuse and microvascular disease, and it provides composite flow measurement reflecting all of these contributions. Then we are also all familiar with the Muga scan, which is usually done for the ejection fraction and the wall motion abnormality. And this is another study which is kind of a gold standard for left ventricular ejection fraction quantitation. In Muga scan, we label the RBCs of the patient with technetium or the radioisotope, and then the cavity is filled, the blood is labeled with the radioisotope, so the cavity of the left ventricle is visualized on the scan, and then we draw the region of interest around the left ventricle, and the ejection fraction is calculated by the software. And similarly, dyskinesias, akinesias or hypokinesias can be assessed. So this is what a Muga scan looks like, where you can see this particular green circle, that is the left ventricle. So once we delineate the ventricle outline, it automatically calculates the ejection fraction. You can see this is the end diastolic and this is the end systolic picture. And then it also does the regional wall motion abnormality. So the entire thing is having a dark color. That means the entire ventricle is showing there is no dyskinesia. It is all contracting in harmony. If there is a dyskinesia, there will be difference in the shades of various areas of the left ventricle. And similarly, regional ejection fraction is also calculated. The phase amplitude is also calculated. So I have another 5 minutes. Okay. So then there's another modality, that is the iodine 123 MIBG, which is used for cardiac sympathetic imaging. So here we use the tracer and it images the cardiac autonomic innovation. And the ratio, if you can see here, the mildly we can see the myocardial uptake of the MIBG. And this is where in a heart failure patient you do not see any uptake. Quantitation is done by ratios of the normal or the mediastinal liver pool. And then you have the ratios which are normal versus abnormal. So this particular imaging predicts arrhythmias and risk of sudden death. So very useful for diabetic neuropathies. So integration of both myocardial perfusion with the CFR as well as MIBG, it can really help to assess the entire cardiac spectrum of cardiac health, and it can guide the therapy and prognostication of the patient. Then we also have the other, which I'll just touch upon as I have already run short of time. So I'll just like to just touch upon the diabetic gastroparesis, where there is a neuropathic involvement of the in diabetes, leading to various disorders or delayed gastric emptying, and the patient comes with early satiety, bloating, nausea. So there's a whole spectrum of symptoms that the patient has. Dr. Ravikant has done a lot of extensive work on this, and we've done a lot of work on gastric emptying studies. So it is the gastric emptying study is the gold standard for diabetic gastroparesis, and here there is mostly expected delayed gastric emptying without a mechanical obstruction. But there are also many other patterns that we've seen. There is a disturbance in the uptake in the regions of the stomach, and we also see hurried gastric emptying, and we also see apparent normal gastric emptying with all the symptoms, where there is a lot of scope to study. So I'll just go through all this. I mean, let's not waste more time. We can do it with solid as well as liquid. We also can do bowel transit, where there are ways to assess the normal versus abnormal colonic transit. So I think if there's no time, can I take another 5 minutes? I have some nephropathy and ortho disease to cover.
Yes,
if you give me 5 minutes.
Try to finish it if possible quicker.
Yeah, okay. So diabetic nephropathy is another problem which leads to global end-stage renal disease, and we have the renal scintigraphy, which helps us to assess the differential function as well as the drainage as well as the GFR calculation. So this is a normal scan where you can see that both the kidneys are taking up the tracer, they're draining well, and the curve is nicely falling. So any subtle change in one of the renal functions, one of the kidneys, will really be very easily picked up on the renal scan. Here you can see a darker kidney, which is the hydronephrotic kidney, left kidney because it's from the posterior view. Then there is a DMSA scan which is done for the cortical imaging, where if the patient has got infection or any pyonephritis, so the sequelae can be studied with a DMSA cortical scan, where you will see a scar as a sequel of the pyelonephritis. So it helps to detect early regional functional data of the kidneys versus the biochemical markers like creatinine and BUN. And it's non-invasive, quantitative and repeatable, and very crucial for longitudinal follow-up. Then coming to the diabetic foot, we all know the Charcot's foot is a very challenging area, maybe mostly for surgeons as well, where it's very difficult to understand whether it is the arthropathy or it is the infection or it's a cellulitis or if it's the osteomyelitis. So that is where nuclear medicine has an edge, where you can combine the WBC imaging with the bone scintigraphy, and it really helps us to understand whether there is prevailing infection, whether the infection is in the soft tissue or in the bone. So combining those two scans, we can really understand and try to manage accordingly. So I'll just show you one image here where you can see that there is uptake on the WBC scan, and in the same area you can see on the bone scan. So it is a bone infection because it's showing WBC uptake. Here you can see uptake on the WBC scan, but there's no uptake on the bone scan, which shows that infection is there, but it's not in the bone. So it's a cellulitis. So this is how we can differentiate between the two conditions. Then this is an experimental. Now we have the pancreatic beta cell imaging which is coming up, and it is really going to be the future where you can actually image the pancreas, and the images are beautiful. There is a new agent that is coming up. Here you can see the normal pancreas, and here the pancreas is not seen. So this is the newer one that is coming up. So diabetes leads to multi-organ functional changes, and these changes come before the structural abnormality, and integrating all these imaging, we can improve the clinical outcomes in the diabetic patients, and we can do it by utilizing various modalities which I just described.
So AI can be integrated. We have theranostics where we can combine some therapeutic isotopes for these complications in the future. And new tracers can be used for further imaging of the neuropathic mapping. Thank you very much.
Thank you, ma'am. I think the talk was actually very wonderful, and most of the areas you mentioned are new to most of the people who are listening to your talk. Yeah, I just have one question. So, in the background of diabetes, somebody who is actually having an uncontrolled hyperglycemia, will these will the uncontrolled hyperglycemia, if it is present at the point of time during the imaging, will it affect the imaging techniques in any way to infer the imaging results?
Yeah, so if we go scan wise, so overall in SPECT imaging or bone scan imaging, it doesn't affect the glycemic status doesn't affect, but we all are aware that PET imaging with FDG is definitely dependent on the blood glucose level, whether we are doing it for oncology or whether we are doing it for cardiac or whatever. So it does affect. So we need to control the sugars, and only then the FDG will go, because FDG is a glucose analog and it will only go in the cell when the cell is hungry for it. So we need to understand that the sugar needs to be controlled. Many times we do refer the patients to diabetologists, even for the oncology patients, when the sugars are not controlled, for the PET scan. So there it definitely matters. But for the rubidium and for the myocardial perfusion imaging, it doesn't matter, the sugar levels.
Thank you, ma'am. Any questions from the audience?
So bone scan is very sensitive for bone involvement. Okay, MRI, why you do it? Because you also have cellulitis and you have the soft tissue changes where MRI has an edge. But if you just want to know whether the bone is involved or not, then the bone scan will be very sensitive. WBC scan is not commonly available, which I am talking about, but we are not doing it. So our orthopedic people always keep requesting for that, but we do not have it. It's very cumbersome, and we need a dedicated technologist to label the WBCs and then re-inject into the patient. So since it's logistically challenging, we don't have it. But for overall diabetic foot assessment, you can definitely go for an MRI. But if you ever want to know whether there is active infection and whether there is a bone involvement, then the bone scan is the first modality of choice.
Thank you, ma'am. We can conclude the session. Thank you.
Thank you so much, ma'am, for such an insightful session. Now I would like to request our chairpersons to felicitate our speaker, Dr. Vandana ma'am. Thank you so much, ma'am. I would also like to request Professor Ravikant sir to felicitate our chairpersons, Professor Surekha Kishore ma'am. Dr. Arvind Sharma sir. Next up, we have a session on evaluation and management of pulmonary arterial hypertension in the context of connective tissue diseases. This session is being led by Dr. Satish Sir, Assistant Professor at Department of Cardiology at Aiims Rishikesh. I would also like to request the chairpersons for this session to come up on the dais. Dr. Kamal Bhatt Sir, Consultant Physician at Rheumatology, Prerna Clinic, and Dr. Prakash Sir, Assistant Professor, Aiims Rishikesh.
Good morning, everyone. Thank you for this opportunity. Today I would like to discuss pulmonary hypertension in connective tissue disorders. So as we all know, pulmonary arterial hypertension is a very common phenomenon, yet very underdiagnosed, and still we are at this level. We couldn't understand the 20%, we could only understand 20% of the disease. So the current prevalence of the disease is 1% in the global population, and the most common cause is left heart disease, followed by the lung disease for the pulmonary hypertension. Compared to the other groups of the pulmonary hypertension, pulmonary arterial hypertension affects younger population, which constitutes about 50 to 60% of the idiopathic pulmonary arterial hypertension. Among patients of the pulmonary arterial hypertension, female predominance is usually seen, which usually ranges from 1.7 to 4.8:1 ratio. So initially, the cutoff level for the diagnosis of the pulmonary arterial hypertension is with a mean pulmonary arterial pressure of 25 mmHg, which is currently revised to the 20 mmHg. The evidence for this is, and there is an adjusted mortality for the 19 to 24 mmHg about 22%. So considering 20 mmHg as a cutoff value for the diagnosis of the pulmonary arterial hypertension seems to be reasonable. So the hemodynamic classification of the pulmonary arterial hypertension consists of the precapillary pulmonary hypertension, combined precapillary and postcapillary and exercise-induced PH. So in the precapillary and combined precapillary and postcapillary, you will see PVR, pulmonary vascular resistance, of about greater than 2 Wood units, and but in isolated postcapillary pulmonary hypertension, you will see PVR of less than 2 Wood units. And the current classification includes grouping of the pulmonary hypertension into the different categories, which consisted mainly of 5 categories. And the group 1, which is an idiopathic pulmonary hypertension and the hereditary, drug-induced and other causes. And group 2 is related to the heart. Group 3 is related to the lung diseases. Group 4 is CTE-PH, and group 5 is miscellaneous disorders, which we couldn't understand yet. So among them, the most common is obviously the left heart disease, as we have discussed, and the next most common is lung disease related pulmonary arterial hypertension. So the main pathophysiology is disrupted homeostasis of the endothelium derived factors in pulmonary arterial hypertension, which leads to the increased vasoconstriction and decreased vasodilation. And the theory of change in endothelial cell phenotype. Initial endothelial injury leads to the apoptosis. Remaining endothelial cells become hyperproliferative and resistant to the apoptosis, leading to the plexiform lesions. In the late stages, endothelial cells become senescent. And the following changes will be seen in the pulmonary vasculature, especially in the pulmonary arterial hypertension, which is medial hyperplasia, intimal proliferation, plexiform lesions, leading to the pulmonary vasculopathy, thereby causing the right heart failure. So the group 1 pulmonary hypertension includes idiopathic, heritable, associated with drugs and toxins, and associated with connective tissue disorders, HIV, portal hypertension, congenital heart disease, and cystosomiasis. So our main topic is connective tissue disorders. Why connective tissue disorders matters in the PH? So connective tissue disorders accounts for 20 to 30% of the patients enrolled in major PH trials, which include systemic sclerosis being the most common among them, especially the limited type of systemic sclerosis. And the phenotypic expression of the PH in CTDs includes the, in these 5 groups which we have discussed previously, includes group 1 is the most common type of phenotype, and followed by group 3, group 2, and followed by group 4. Systemic sclerosis related PH carries worse prognosis compared to the idiopathic PH. So in the diagnostic algorithm, first step in the diagnosis of the PH in a patient with the CTD, the clinical symptoms of the patient, followed by the laboratory, and if they are positive, and then we'll go for the imaging diagnosis, and if it is for the if it is shows the features of the PH, then we'll confirm it for the RHC. Without RHC, without right heart catheterization, we will never diagnose a PAH with a certainty. So the electrocardiogram features which you have to see in the pulmonary arterial hypertension, which you suspect is P pulmonale of greater than 0.25 millivolts, right heart deviation, RV hypertrophy, right bundle branch block, RV strain pattern, and prolonged corrected QT interval. And one most parameter and most ignored parameter in echocardiography, even by the cardiologist, is tricuspid regurgitant velocity. So whenever you suspect a patient with an exertional dyspnea, unexplained exertional dyspnea, the most important parameter that helps for us to suspect, at least not for the diagnosis, is the tricuspid registration velocity. If the patient is having 2.9 to 3.4, he'll have an intermediate probability. If the other features of the pulmonary hypertension, which we are going to discuss, are also present, then it will become a clear-cut indication for the right heart catheterization. If there is greater than 3.4, if the tricuspid registration velocity is greater than 3.4, you can directly go to the right heart catheterization for the diagnosis of the PH. So the other parameters include RA volume and peak tricuspid registration velocity of greater than 2 milliseconds, and RV LA basal diameter ratio greater than 1, and systolic peak velocity less than 9.5 centimeter per second. These are the other parameters which we usually see for the suspicion of the pulmonary arterial hypertension in a patient. And screening for the PAH in CTD patients, especially in light of systemic sclerosis, is every systemic sclerosis patient should undergo annual evaluation for the pulmonary hypertension. And using the DETECT algorithm in adult systemic sclerosis with a disease greater than 3 years, FVC of greater than 40, DLC of less than 60 is a class 1 indication. And transthoracic echography based screening in all CTD with symptoms, signs or abnormal biomarkers. Consider CPET, exercise echo, CMR in equivocal cases prior to the RHC. So the DETECT algorithm includes FVC by DLCO ratio usually greater than 1.6 consider as a risk of PH, and presence of telangiectasias, anticentromere antibody, anti-proBNP, serum urate levels, and ECG showing the right axis deviation. And the echocardiography variables are right atrial area, tricuspid registration velocity. If the combined score is greater than 2, you can refer the patient for the right heart catheterization. So the comprehensive workup in CTD related PH is pulmonary function test, includes DLCO and ABG, high resolution CT to rule out ILD and PVOD clues, and ventilation perfusion scan, autoimmune panel if not known before, and HIV, hepatitis, thyroid profile, a CMR for RV size, and cardiac magnetic resonance for RV size function, TAPC, and right heart catheterization with vasoreactivity testing. Only if the CTD is not well established, the vasoreactivity test should not be done in a CTD patient because it actually detrimental and may lead to the collapse of the patient on the table. So the most important test among these to have a basic idea of what is the cause of this pulmonary arterial hypertension is HRCT, which gives a basic idea whether it is lung related or pulmonary vasculature related or it is an idiopathic cause. Or echo gives a cardiac causes if there are any, and also for the estimation of the RV dysfunction. So once the establishment of the disease is being done, the most important thing we should do, which often being ignored, is the risk assessment of the patient at the first diagnosis of the pulmonary arterial hypertension, because pulmonary arterial hypertension is notorious to worsen rapidly. And so if you can detect the patient and if you can classify the patient early, so the most important factor for the monitoring and upscaling of the treatment depends upon the risk assessment. So one should never ever ignore the risk assessment of the patient diagnosed with a PH. The risk assessment, initial stage, you will follow a 3 strata, which includes a comprehensive detailing, which contains laboratory, symptomatology, imaging, and hemodynamics of the patient. But in the 4 strata model, you will have a functional and laboratory assessment of the patient. So these are the parameters you will see in a 3 strata model. All these parameters you have to assess initially at the time of the diagnosis. But the follow-up, you have to go for the 4 strata model for the clinical assessment of the patient. So coming to the treatment, in non-high risk patients, initial oral combination therapy, there is no treatment of individual treatment for the PH. You have to start with the combination therapy. This is the guideline directed therapy. The initial oral combination includes endothelin receptor antagonist followed by PDE5 inhibitors, phosphodiesterase 5 inhibitors. Example, ambrisentan tadalafil instead of sildenafil. Tadalafil is preferred in the initial stages because it has a pill burden, lower pill burden, and once daily pill, and it have a consistency in the effect showing on the pulmonary vasculature. And high-risk patients, you should directly go to the prostacyclin analogs like parenteral, IV, AP, prostacyclin, treprostinil, and along with the endothelin receptor antagonists and PDE5 inhibitors. And sequential escalation, if risk remains intermediate in the follow-up, 3 to 6 months follow-ups, and add prostacyclin pathway agent or switch PDE5 inhibitor to the SGC like riosigouat. Avoid CCBs, especially in CTD-related PH. manage comorbid ILD, reflux, OSA, and vaccination, and supervised exercise and rehabilitation. This is the flow chart to start the treatment. So once the diagnosis is confirmed, patient without cardiopulmonary comorbidities, in the sense of there is no low LVEF, left side of the heart is not affected, and low or intermediate, you will start with the endothelin receptor antagonist with PDE5 inhibitors, which is a class 1 indication. If the initial risk assessment itself is high, you will go for the initial ERA PDE5 inhibitor along with the IVR subcutaneous prostacyclin agonist. And in the regular follow-up, if 3 to 6 months follow-up, if the patient comes into the low category from the intermediate, low to mediate, then you can continue with the therapy. If the patient stays currently in that strategy, in that risk strategy only, if the patient is still in intermediate low, you will add a prostacyclin receptor agonist, or you will go for the switch for PDE5 inhibitors to the PDE5 inhibitors to soluble guanylate cyclase agonists, stimulators, basically riociguat. So if the patient is having cardiopulmonary comorbidities also, we'll start only monotherapies and then assess the risk assessment followed by the escalation of the treatment. So management of pH due to the CTD related ILD, and which fits into the group 3. So optimizing the ILD therapy, long-term oxygen therapy, and inhaled treprostinil improves the 6-minute walk distance and is guideline supported for PH-ILD. Avoid routine ERA use in IPF, individualize in CTD ILD. Refer early to PH center. Transplant evaluation is in advanced disease. So the key points for CTE PH is lifelong anticoagulation. All patients should be evaluated. The one most common conception is CTE PH is untreatable and it should be should be treated with anticoagulation and the PH medication. No, CTE PH can be treated and it completely can be resolved if it is evaluated by the right person. If the ventilation perfusion mismatch is seen, clear cut, send it to the CTVS surgeon for the assessment of the who is an expert in this category for the treatment for the endarterectomy, which is more. If it is not, then balloon pulmonary angioplasty can be done. If it is not, then you can go for the SGC, which is more beneficial in CTPH. CTPH is an entirely different disease in itself. So every CTPH patient needs an evaluation from the multi-departmental assessment. So special considerations in CTD include systemic sclerosis often responds less robustly, escalate earlier, watch for the PVOD phenotype, which are the markers are low DLCO and HRCT signs. And pregnancy, high maternal risk in PHE, counsel effective contraception, manage in expert center if pregnancy occurs. Renal crisis with high doses steroids can be seen in systemic sclerosis, so avoid unless required. So vaccinations include influenza and pneumococcal. And current therapeutic, even though all these treatment options are available in pulmonary arterial hypertension treatment, still we are suboptimal in achieving the patient quality of life. So and still there are a lot of pathways where we can explore, and the current trials are being done in serotonin pathway, PDGF pathway, mTOR pathway, and activin 2 receptor and BMP pathway. Hopefully they'll give better results. So what do we do in refractory patients? So obviously we need to relieve the pressure from the right side of the heart. So which helps, if a patient is already planned for the transplant, go for the mechanical circulatory support. If there is no other option, go for the right to left hand. Atrial septostomy, for me, I personally prefer atrial flow regulator, which gives, because atrial septostomy, even though it relieves the pressure from the right heart pressure, it has a 25% of the closure in the initial 2 months. So it is always go for the atrial flow regulator, where we induce a balloon expandable device into the atrial septum, and which controls the regulator, which diameter varies from the 4 to 10 mm, which depends upon the body surface area of the patient. And obviously there is pot shunt, and finally there is lung transplantation. And the newer treatment, one of the newer interventional treatment is pulmonary artery denervation. The rationale for using this is a hyperactive sympathetic nervous system is one of the cause is been implicated in the pulmonary arterial hypertension. Negative inotropic chronotropic effects of the beta blockers may further impair right ventricular function and cardiac output in PH. So that's why we can't suppress the sympathetic system with the beta blockers. It is better to go for the pulmonary artery denervation. The pulmonary vasculature is predominantly innervated by sympathetic nerves with branches forming an adventitial nerve plexus. At the left side of the main pulmonary artery bifurcation, the sympathetic trunk is less than 1 mm from the arterial lumen. So here is, this is where you go for the pulmonary artery denervation. And this is the data until now. We have a 6-minute walk distance improvement, and PVR has been decreased, both of them have shown statistical significant effect. So follow-up and monitoring. Every 3 to 6 months, you have to assess the functional classification, and periodic right heart catheterization is, if status changes or advanced therapies, CMR for RV assessment when available. Use force-data tool to track progress aim. And the pitfalls is, do not label pH as pH without ventilation perfusion imaging to exclude CTE pH. Avoid CCBS in CTD pH. Look for the POD clues. Prostacyclin may trigger edema hemorrhage in these patients. In CTD ILD, focus on lung disease first. Watch for the hypoxemia and deconditioning. Key takeaways. 2022 ESC guidelines have lowered an MPAP threshold and introduced a PVR of greater than 2 units for the pH. CTD pH follows pH algorithm. Annual systemic sclerosis screening and detect algorithm reduced missed pulmonary arterial hypertension diagnosis. Use risk-based initial combination therapy. Escalate early in systemic sclerosis. Tailor to phenotype and manage in PH centers. Thank you.
Very good presentation, because this is a very topic which is not discussed much. And it needs concern, because in centers which are teaching hospital like Aims, we need a discussion between cardiac surgeon as well as cardiologist for proper assessment and management of such patients, because many of the patients go undiagnosed, or at times they are managed not in a very effective manner, which lead to further morbidity and mortality. So in our hospital, what is the data that you are pursuing or that you've seen which can be discussed here or managed? Anything that you want to mention, especially concerning our center?
I think cardiologists should do more right heart catheterizations for the definite diagnosis of the PH.
Are we doing it here?
Yes, sir. Yes, ma'am. Since I have joined, I think I have done it, and I am trying to do it more and more. So it actually helps the patient with PH. I know we can't completely treat it. At least we can give them a decent life for a few more years.
If you
with
manage
the
it on
PH.
time. So.
Yeah. The timing is very important in the treatment of the pulmonary arterial hypertension. So because once it sets in, once the complete permanent changes have sets in the pulmonary artery, there is nothing we can do apart from the lung transplantation, which also have its own limitations. So we have very little window period, and which we have to use it efficiently.
And Uttarakhand is a very hilly terrain, but Aims is draining also area which is from plains of UP as well as Uttarakhand and surrounding Himachal. So what is your patient profile that you are seeing, the common age group that you are seeing, and the patient profile?
Ma'am, as I have discussed, it is always the left heart diseases that are more commonly associated with pulmonary arterial hypertension. Idiopathic is I don't think, maybe we are underdiagnosing it, maybe we're not catching the enough patients, but idiopathic I have hardly seen like in an year not more than 100 patients. Even though 100 patients are also more, I'm considering it more, I'm telling even below it. So
if you say 100, that means every third day you are encountering a patient.
But
in
that is
situation,
escalating.
I would want to know, have you seen any particular area of Uttarakhand that you are seeing patients come from who have this? Have you noticed demographically any area which can be focused later on through community outspread and where social outreach can be done and you are encountering? I think we need studies in that regard, because Aims Rishikesh is draining not just Uttarakhand but also patients of UP. And Himachal surrounding area.
Yes,
so we need to focus on the demography also, and we need to know if patients are reporting from which major area, so that we can then have a social outreach and preempt our work and have a early diagnosis and manage such patients and create awareness also. Because unfortunately most of the patients come very late. They report very late. At that time the outcome is already dismal. So
yes, ma'am. Even in the medical community itself, the evaluation for the undiagnosed exertional dyspnea is not so much. So you'll just do an echo and you'll say your heart is fine. No, even the diastolic dysfunction, as mentioned earlier, is diagnosed little bit lesser compared to the remaining diseases. I think exertional dyspnea is one thing where we have to work up. If it is really a major concern for it is affecting the quality of the life, we should be admitting the patient and doing more workup for the patient. It might help the patient.
Because just like hypertension, just we have a Euro score where we assess the risk of the surgery which is a European guideline, so that Euro score for all the PG students who are doing MD. So we assess that according to the Euro score, we give a number to every comorbidity, and accordingly the score will decide whether the surgery is going to have a better outcome or is going to be a high risk. So hypertension is usually given number 1 only, 1 point only in that Euro score. But now recent studies have now found that hypertension is an area that needs focus, and unfortunately, especially in women, patients will say, my husband has BP, but they never go for preventive checkup, and hypertension remains undiagnosed. Leads to diastolic dysfunction, leads to dilatation of aorta, and when the patient reports to you, the patient already is in a decompensated state. So now hypertension, especially in women, like dyslipidemia in women, again is a topic which is now requiring newer focus, and now people are focusing more and more on not just overall, but especially a gender specific, because that area remains under diagnosed and under evaluated also. They don't go for preventive checkup. Same is for this pulmonary hypertension. People are not even aware of it as a separate entity. So when the patient comes to you, most of the time it is not diagnosed or underdiagnosed, or the patient comes to you when you are not able to help the patient.
I agree, completely.
Just congratulate you on a very nice topic. I just want to comment from the point of view of rheumatologist or pulmonologist or general physicians who are looking after the patients of connective tissue disorders. So when we evaluate a patient for cough and dyspnea, most of the time we stop at diagnosing ILD. So we think that we have found the cause of the dyspnea, but like you said, we should always screen for PAH even at the first visit. Even if there is no PAH at onset, we should keep monitoring, and we should not stop at diagnosing patient as ILD. And especially when we refer for screening, it should be pointed out that I have seen personally that if you do not point it out that we are sending echo for PAH, sometimes it's missed. So thank you for that.
Yes, sir. I agree.
Thank you, sir, for that excellent session. May I request our chairperson to kindly felicitate our speaker, Dr. Satish, sir. Next, may I kindly request Dr. Namrata Gaur ma'am and Dr. Prakash sir to felicitate Dr. Kamal Bhatt sir. We now move on to the interface of oncology and endocrinology with targeted therapies and hyperglycemia in oncology. Our speaker for this session, Dr. Aditya Sir, Consultant and Assistant Professor at Department of Medical Oncology, Gangaram Hospital, Delhi. Welcoming our chairpersons for this session, Dr. Deepak Sundriyal Sir, Professor at Department of Medical Oncology, Aims Rishikesh, Dr. Amit Sherawat Sir, Assistant Professor at Department of Medical Oncology, Aims Rishikesh, and Dr. Anirudh Mukherjee Sir, Associate Professor, Department of Medicine, Aims Raebareli.
So, first of all, I would like to thank Organizing Secretary, Dr. Anirudh. And
let me introduce you for a second. So, a very warm welcome to Dr. Aditya Sareen, who is working as a medical oncologist in Sir Gangaram, New Delhi, and also happens to my dear batchmate. We were best of friends during our MD days. Yeah. And wishing you a very happy birthday also. You took
thank you. So yeah, we were together in the trenches of our residency, so I can't say no to him. Even though when I go back, my wife is going to do some bombardment over me, but then again. Okay, so we all know and we have seen and experienced that in the past 10, 20 years, the incidence of cancer amongst the family, the relatives, it's bang on rising. And the term which oncologist, the cancer term which was taboo, which nobody was using it 5, 6 years back, now they are like, it's rampant now. And with this comes our responsibility as oncologists to share our experience that what are those nitty-gritty points of some molecules that should be known at the community level, because we are using these molecules day in and day out, and they are creating havoc in the management of hyperglycemia. Obviously, they have a lot more complications, but considering this talk, I kept my talk in a very specific way, which is defying the sweet trap, managing the hyperglycemia in the era of targeted and immunotherapy. So I'll start with the case of mine. She's a 35-year-old female diagnosed with a metastatic carcinoma lung, and when she presented to us, she was having vomiting, headache, backache for the past 10 days and bilateral lower limb weakness and blurring after passing the stools and decreased appetite for the 2 months. And she got admitted this year in Jan 2025, so it's a very recent case for us. But the history dates back to 2020, where she was diagnosed with ALK positive. ALK is again a mutation where you can target these with ALK inhibitors. And this was way back in 2020. And again, the disease was metastatic stage 4. So it has spread to bones, non-regional nodes, and multiple brain mets. So this patient was taking alectinib till 2 years. She was fine. Then at the end, in 22, she was given radiation to the lung again. In 23, so till 23, patient kept on doing well with just single pill and no chemo was given to this patient. Then in 23, she landed up with a progression and put on decongestive therapy because the brain lesion started to increase, and somewhere outside, she underwent a dendritic cell therapy. Again, this is not a category 1 recommendation for us. Then finally, she was started on this tablet, which is lorlatinib, and it was stopped in view of clinical worsening of the patient's cognitive changes and hyperglycemia. So the PET scan, if I were to show you, it was a hell of a time for us to get the PET scan. So this was the previous PET scan. You can see at the baseline, these all light up yellow spots. Patient was having multiple liver, skeletal, spinal cord, and sacral lesions. And let me just dive down ahead a little bit. So we were having a problem that patient is absolutely bed-bound, anxious family. They have taken 5-6 opinions pan-India. You know, everybody likes to do shopping, doctor shopping, I call him. But then again, when you are sitting in the center of India and center of Delhi, you are bound to get these opinions. So everybody suggested, you start the patient on the next line of treatment. And you give the patient for palliative radiation because one of the tumor of the spinal cord was impinging on the cord, which led to the paralysis. And that's why she was having a complete paralysis lower limb and a bladder bowel involvement. And she was just 37 kgs and a seizure episode, one seizure episode as well. So we were under a lot of political pressures whether to treat or not treat, and me being quite a young one in the practice, so obviously I had the other issue of whether to trust the doctor or not. But the good point about us, me and Anirudh, that our training at the level of MD medicine is so stubborn and stern that we generally don't miss on the errors. And a good history taking is very essential in any of the case management. Whether you are dealing an oncology patient or a non-oncology patient, you have to have a good amount of history taking, thorough history taking. So this was going through my brain. Let us just get, I think we should leave this patient. We should not treat, I think let her go peacefully. And we should just submit her to palliative care. But the relatives' thought process was that it's a money-making business, and this is a common statement now, at least in my setup. Will she even make it? And even if she makes it, is she going to have a troubled quality of life? So what's the point of treatment? जब उसने जिंदगी अच्छी जीनी नहीं है तो फिर इलाज ही क्यों कर रहे हैं डॉक्टर साहब यहाँ पे? पेशेंट को हम घर ले जाते हैं और फैमिली मेंबर्स के पास रखते हैं और अगेन पैन इंडिया आई हैड लाइक मल्टीपल ओपिनियंस So at that point of time, it was like a fight between a Tyrannosaurus or a Triceptosaurus. And because you are challenged day in and day out, you have 10 more things to do, but then again, one patient is going to consume a lot of energy. So then we did a good amount of counseling, and ultimately we utilized simple common sense. We blurred the background noise, we blurred all the political pressures. And when we started the treatment, her sugars were ranging in the range of 400, more than 400 in fact. And we had to involve a psycho-oncologist to help us dial down the drug-induced cognitive changes. We started her on pemetrexed and carbo, and again restarted her on tablet lorlatinib. We gave her some blood transfusion and SDP, and we discharged her comfortably within a week. Now, if we were to see 4 months down the lane, you see all these yellow spots are gone. So this was the previous scan, and in a snapshot, you can see that we had hit the jackpot in terms of saving a life. These all responded beautifully, and in the next PET scan, you can't see any of the visible disease. So what helped us? At that point of time, when history was somewhere here, where patient was this point, this was the change fulcrum point in this particular case. So hyperglycemia was one problem, then hyperglycemia leading to neurocognitive imbalances, and then again lorlatinib itself causes neurocognitive imbalances. So when we were able to pinpoint that these were the main issues, and she can still respond to lorlatinib, and you get these responses. Even though patient is still having paraplaces because of the damage that has been done, I can't unfortunately, reverse them, but she is fine. And last week she came to me in OPD again with a similar PET scan. Patient is still under disease remission. So what I want to highlight right now is these targeted therapies, right now they are costly, but then maybe 2 or 3 years down the lane, these are going to go cost-wise way down, and at community level. We have to know that these require some special tweaking of the hyperglycemia management. Your regular anti-diabetic medicines are not going to work. Some tweaks are required. So again, a lot of bony disease and all you can see in the follow-up PET scan, it's gone. So I've kept it very basic and simple. You can see the brain lesions. Even in PET scan, they are lighting up. Even though we say that PET scan is not the ultimate weapon for diagnosing the brain lesion, it is the MRI brain with contrast. I really didn't require anything because the fantastic response she was having. So this case isn't about glucose alone, and I think it's about our grit and young oncologist and young consultant, in whichever specialty you guys are, choosing science over skepticism and proving that vigilance is the finest credential. That should be the take-home message from this learning. And coming on to the targeted therapies, so therapies like anti-EGFR, HER2, VEGFR, PI3K inhibitors, mTOR inhibitors, or cell cycle regulators, we are using it day in and day out. You'll be surprised that 20% of cancer patients have concurrent diabetes mellitus, and hyperglycemia during chemotherapy can increase by 30%. Because most of the time we are going to use steroids in our pre-medication, which can ultimately land the patient in hyperglycemia. So you have to be again on high alert. So that's why I say, so the problem now I'm facing is that in medical oncology, you can come either via a pediatrics route, either via the medicine route, or by the radiation oncology route. So for medicine and pediatrics, they do know how to handle the dynamics of the sugar, but then the patients, so the students who are coming from the rad onco, they need little bit of assistance. So I was just thinking that this should be the right platform to guide that at least radiation oncology should get their postings rotated in the medicine as well, so that they can have a good amount of idea how to manage hyperglycemia once they become oncologists. So the risk factors of any cancer patient, if we are going to give like mTOR inhibitors or PI3K, or if we were to talk about lymphoma, where steroid is the main modality of treatment, one of the main modality, you are bound to have more and more of hyperglycemias. So hyperglycemias can happen, I think the pathways like PI3K, AKT, mTOR pathway disruption, IGF-1R signaling alteration, or upregulation of gluconeogenic enzymes. So there can be insulin resistance mechanism, or there can be some drug-specific mechanisms. If we were to see the incidence, everolimus or temsirolimus is leading the highest incidence by 50%, PI3K, alpelisib is again 37%, AKT inhibitors 30%, and you have other checkpoint inhibitors. Even though immunotherapy side effects are very less, it is less than 1%, but then again, when you are giving immunotherapy regularly in day-to-day practice, you are bound to see all the complications of immunotherapy. So some specific drugs, if I were to talk about, like everolimus, you can see incidence 50%, temsirolimus, alpelisib, osimertinib, and midostaurin. And you need to know about the risk factors. So obviously patient who is having, older age, obesity, family history of diabetes, pre-existing diabetes or impaired, HbA1c. These are our patient-related factors. So you can pre-screen your patients before prescribing such medicines. And obviously as oncologists, we have to hone our senses. As soon as I'm writing mTOR inhibitors or I'm writing any ALK inhibitor, I need to be on high alert that these patients are going to require a special care. So what we do generally, it's a tandem communication with me and my physician and my endocrinologist that right now I'm going to start this drug, you better get yourself involved, and these are some specific points that you have to know from my side. So obviously clinical presentation, I don't need to tell the audience about how hyperglycemia presents, but what I am going to discuss about is some very specific features. So let me just dive down into this. So if I am using PI3K inhibitors, so preferred treatment should be metformin, or you can add DPP4, and you have to avoid SGLT2 inhibitors over here. So one-liners, that should be good enough over here. If I am using capivasertib, again, you can give metformin or DPP4 and insulin for severe. Kindly don't go beyond this recommendation, because if you do, the problem becomes the ketosis. For immune checkpoint inhibitors, you have to give only insulin. Your tablets are not going to work in immunotherapy-induced hyperglycemia. Some more examples like lorlatinib for this patient. So I had to use either GLP-1 or SGLT2 or metformin. So then again, you see, every drug has its own different mechanism of action, and then again, how you are managing with that different therapy of anti-hyperglycemia, that is also different. And these drugs like nilotinib, ponatinib, so a lot of our CML patients are on this drug, and the main recommendation is you better use only metformin or SGLT2 or GLP-1, but starting with metformin. Glucocorticoid, you all know how to manage. And so I have recently started using these molecules like sulpercatinib, again not available in India, had to import it, and now patient is manifesting hyperglycemia again. Now I know that what I need to inform my endocrinologist. So it's a tandem communications. That is why oncology is a branch of multidisciplinary approach. Every patient before starting should go through a rigorous and a thorough molecular or a MDT, multidisciplinary tumor boards, because your therapy related outcomes, your prognosis, your OS, your PF will be defined in that tumor board. So I think with this I just thank you. Thank you. And I have a minute left here.
Congratulations, Dr. Sareen, for this wonderful summary of the topic. I would like to add few things to it. First, our experience at Aiims Rishikesh. So we have done some work as a part of MD medicine thesis.
Yeah.
Out of 100 odd patients, around 10% of the patients, they were having pre-existing diabetes. Over the course of 6 months, that percentage jumped to 18%. So that means, irrespective of we are using a costly therapy, advanced molecular, we must always be concerned about diabetes management.
Absolutely.
Those who are having already diagnosed diabetes, as well as subsequently they are going to develop diabetes.
Yeah.
That's the first thing. Second thing that is important for all the medicine residents, that with biosimilars and generics, all these targeted therapies are going to be much more cheaper, much more available for our day-to-day practice. For example, immunotherapeutic agents.
Yeah.
They are going to have all kind of endocrinopathies, including poorly controlled diabetes. So that is going to be our main concern. So we must be oriented that those patients who are getting any kind of targeted therapy, including immunotherapy, those who are in pre-existing diabetes, we must be stringent. We must always check drug-to-drug interaction. Then we must start the targeted therapy.
Absolutely.
And those who are not having diabetes, still we need to be very particularly about this use of steroid as a pre-medication, post-medication. That will always be making prone for development of new diabetes in these patients.
Yeah, absolutely.
Thank you.
Thank you.
So this was all about diabetes and those patients who develop diabetes during targeted therapies.
Yes.
So I have only one question. What about those patients who have a pre-diabetic status prior starting this therapy? What is your approach in those cases?
So you straight away start with high doses of their anti-diabetic protocol. For example, if I were to start with any patient on lorlatinib and that patient is having diabetes,
No. That patient is pre-diabetic, not
that's,
diabetic.
So that patient, again, I might be having a stringent follow-up in my OPDs. As soon as the patient lands up into the diabetic zone, he will eventually land up. To be honest, lorlatinib is one of those drugs where my 80% of patient with the full dose of lorlatinib will land up in hyperglycemia, even if patient is a non-diabetic. So if you are telling me that patient is pre-diabetic, I am very well, aware that in 3 months or 6 months or 10 months, this patient is going to require a good amount of anti-hyperglycemic measures. You can just be aware and start the treatment before the hyperglycemia-induced changes happen in that particular patient. Because see, these drugs are life-saving for such scenarios. I can't stop the drug, I can dial down the dosage of the drug, but then again, diabetes management in terms of where I have to use SGLT2, where I have to use DPP4, where I have to use metformin, that should be crystal clear.
So mechanism in most of these cases is insulin resistance.
It is different for everything, like your Aadhaar card will not get matched with my Aadhaar card. So the treatment of one class of agent is not going to be answered in a blanket statement. So if I am to use mTOR inhibitor, their pathway is different. If I have to use ALK inhibitor, their pathway of causing hyperglycemia is different. It's a long talk, I can go on and on, but at the end of the day, I think it's going to be like a fingerprint management.
Yes, yes.
It is individualization, and this is why we are landing up in the era of precision oncology.
To be very specific, I want to know, would you like to use metformin in pre-diabetic patient, or you will...
Not
start
like that.
treatment
If the
only
patient
at the
sugar is
beginning of
not
diabetes?
coming up, so I will not recommend upfront. Okay. Only when the patient lands up in real hyperglycemia.
Now more and more evidence is for use of metformin for oncological indications also. So,
So
that makes some theoretical sense. in
You
using
have
metformin in
even
pre-diabetes.
role of metformin as a cardioprotective, as a oncoprotective effect as well. So I'm not debating that. So I just wanted to highlight how these molecules of different pathway create turbulence in our life. And I have to inform my endocrinologist, because see, if I am sitting as an endocrinologist, I might not be aware of all the molecules that an oncologist is using. And I will never be aware of all the molecules that an endocrinologist is using. So we have to create a common bridge where my thought process, the literature, and they have to come in the same picture, and we both give benefit to the patient.
Yeah, I think, congratulations, Dr. Sain, wonderful presentation. I think this is definitely a newer, field to explore more and more. Here we call upon the need and to, come up with at least some recommendation, maybe primitive one, for addressing hyperglycemia, metabolic syndrome in oncology patients. I don't know what is the rationality of using OGTT even before starting these molecules. I have no idea as of today. But probably we can devise some mechanism by which there could be a predictive model depending on the risk scores and maybe by OGTT or maybe some challenge test. I think future can only decide. But definitely it calls upon a bigger call to take upon for better management of these patients. This is what my comment is. Thank you.
Absolutely. Thank you.
Thank you so much, sir, for shedding light on this emerging clinical concern. May I request our chairpersons to kindly felicitate our speaker, Dr. Aditya, sir. May I request Dr. Anirudh Mukherjee, sir, to felicitate our chairpersons, Dr. Amit Sherawat, sir. And Dr. Deepak Sundriyal, sir. Our next session takes us into the fascinating world of rheumatology with a talk on rheumatoid arthritis mimics, a case-based approach. To take us through this highly practical and engaging topic, we have with us Dr. Kamal Bhatt, sir, consultant physician at Department of Rheumatology from Dehradun. To chair this session, I would invite Dr. Rajkumar, sir, additional professor and head Department of PMR, Aiims Rishikesh, and Dr. Rajat Ranka, sir, consultant physician at Department of Rheumatology from Dehradun.
Good
Good morning, everyone. I would like to thank the organizers for giving me this opportunity, and especially Professor Ravikant sir for inviting me here again. And the topic given to me is RA mimics, a case-based approach. So I think the idea behind is not just to present a differential diagnosis in a didactic way, that would be too boring. So I have tried to include a few cases, real life cases which I have seen over the years, and to show that how do we go about in a clinical way. And before we proceed on to what is not RA, let's just have a look at what is RA. What is the entity and how do we define it and how do we say that this is RA, and then we will see that how we say that this is not RA. So theoretically speaking, these are the classification criteria. Mind you, these are not diagnostic criteria, these are the classification criteria. And just to highlight a point that the diagnosis in rheumatology is primarily clinical. It's not based on investigations, and these criteria also highlight this point that if you look only at investigations, that is abnormal inflammatory markers and positive antibodies, you still get a score only of 4. So in a patient of synovitis, if you have positive investigation, your diagnosis is still not complete. On the other hand, if you do not have any investigations, but your clinical diagnosis is there, means that a duration of 6 weeks and diagnosis synovitis of MCP joints, you can have a score which can confirm your diagnosis of rheumatoid. It doesn't mean that investigations do not play a role. So if you combine your synovitis with your positive antibodies, these antibodies felicitate an early diagnosis even before 6 weeks. So the earlier construct that you need a chronic synovitis lasting more than 6 weeks, it is not there. You can diagnose within 2 weeks if you have positive antibodies. But the basic idea behind it is that the diagnosis has to be clinical. Investigations play a secondary role. And how do we do it clinically? So the most important term, both in basic immunology, because you might be aware that in basic immunology, how our immune system recognizes foreign pathogens is by pattern recognitions. And so all clinicians also who work in rheumatology, they are also have to be fluent with pattern recognition. All diagnosis in rheumatology is basically pattern recognition. And you have to fit certain symptoms and signs into patterns, and then you need to look at some extra articular features. So how do we recognize those patterns? Whether the pain is articular versus non-articular. If it is articular, whether it is inflammatory or non-inflammatory, we all know what are the signs of inflammation, Werkow's triad, that dolor calor, that is morning stiffness, swelling, morning stiffness lasting more than 30 minutes, swelling limitation like these. And then those patterns of inflammatory arthritis. These are some of the common inflammatory arthritis which we encounter in a day-to-day practice. And for the current topic, we are concerned with this, a chronic symmetric polyarthritis primarily involving hand joints, that is wrist, metacarpophalangeal and proximal interphalangeal. These are the classic signs, classic joint involvement in rheumatoid. So this is the entity which we say as rheumatoid. Now we will proceed to what is not RA. So to say that it is RA or not, sometimes the most important clue is not in joints but in some extra articular features. And the one on the right side of the slide are the ones which can exclude your diagnosis. So you have to pay more attention on them. If any of them are present, your diagnosis might be in doubt. It's not that those on the left side will confirm. It's not for rule-in. Like for example, if you have ILD, you cannot be sure that it is rheumatoid. It can be present in other ILDs, but yes, ILD is consistent with a diagnosis of rheumatoid. But those on the right side like fever, uveitis, in RA it is mostly episcleritis or scleritis, but if it is uveitis, you might have to think again. Then skin rash, of course, active urine segment, muscle weakness, cytopenias, weight loss, and sometimes pain out of proportion to your objective synovitis. So with these features, you can say this is not RA. So these are some of the common differentials. I will not go into those details. Probably you might have heard and read about them. So we will move on to the first case, a young female who came with joint pains and swellings of 6 months duration, symmetric involvement of hand joints. ESR and CRP were high, rheumatoid factor was just positive, anti-CCP was negative. She was diagnosed elsewhere as rheumatoid and given a combination of standard therapy, NSAIDs, short course of steroid and DMARDs. But then she developed some skin allergies, forearms, erythematous maculopapular rash, for which she consulted some dermatologists. She had some mild symptomatic relief, but thinking that either NSAIDs or hydrochloroquine or sulfasalazine, which are the common culprits, might have caused this skin allergy, these were stopped. Now, when she came to me, she had 3 months of these therapies. She was only on low-dose steroid and methotrexate, and she still had off and on skin rash. There was no fever or other features like which can suggest connective tissue disorders. ANA and ANCA antibodies were negative, urine was normal, routine investigations were all normal. So how do we proceed? Is it RA or it is some connective tissue disorders or possibly vasculitis? So what is the further workup which we need here? More serological testing, repeat testing. Sometimes we are fond of doing repeat. Let's order everything again, right? And maybe nerve conduction, imaging or biopsy. And what are the treatment options now? Because 3 agents, she probably has a skin allergy, and 1 methotrexate, she is not responding, so maybe we should move on to JAK inhibitors or some biologics. So before that, let's have just our common sense dictates that we should have a look again, and we should have not only a dermatology opinion. I think if you just refer, they will say it's a skin rash, patient is on these many drugs. But I had a discussion with dermatologists that can we do a skin biopsy because she's not responding. And the skin biopsy showed, surprisingly for me, because this is the first case I have seen in Uttarakhand. Maybe there are other cases which might have missed. She showed epithelioid granulomas. And the dermatologist and pathologist confirmed that it is Hansen's disease. So this is one differential, although I'm not sure how common it is. I trained from Allahabad, so it was a common disease there in UP still, but I think Uttarakhand also has reported. I just read about a report from Srinagar Medical College that they are still seeing in hilly areas, Hansen's disease is still common. Although it's low as far as the WHO criteria of elimination is concerned, but Hansen's can cause inflammatory arthritis exactly mimicking rheumatoid and without any neurological or dermatological manifestation. Second patient, a middle-aged lady, again symmetrical polyarthritis of 2 years duration now, no extra articular features here. She was diagnosed as RA, again standard treatment. She had partial relief, but then she had borderline liver derangement, so methotrexate was reduced expectedly, and ultrasonography, viral markers negative. What further evaluation is needed and what further treatments are needed. So when she came to me, she still had, the main complaint was she couldn't get up from a squatting position. So earlier physicians had seen her and her husband was in ONGC. They had been seen by rheumatologist also, and everybody thought that it is still knee osteoarthritis or active synovitis, which is the main problem. But what she had was a muscle weakness in quadriceps and truncal muscle weakness. Her joints were absolutely normal. And muscle enzymes were elevated, and then AST, ALT elevation was not because of the liver. We have to remember that they can come from muscles also. And then furthermore, electromyography and MRI thigh confirmed that she had active myositis. So probably her diagnosis was now, because of arthritis and myositis, it was possible MCTD. And rather than reducing methotrexate, I increased the methotrexate doses along with some steroid, and she responded well, and later on azathioprine was added. So we just don't believe that if patient is saying that I cannot get up, it's mean that the knee is involved, it might be muscles also. Then an an elderly male, pain, swelling of elbow, MCP, PIP, DIP, knee, ankle and MTP joints for 6 months. He had subcutaneous nodules consistent with a diagnosis of rheumatoid. ESR was elevated, rheumatoid factor positive. Again, he was being treated as a case of rheumatoid, but he had only partial relief. And also he had elevated blood pressure, creatinine was on the higher side, and possibly he had CKD. So, further review, these possibly might give some clue clinically that the subcutaneous nodules were just over olecranon, and the other nodules were firm. Or a review of history again told, because see what happens sometimes, these kind of patients, they will tell you whatever their current problem is. This gentleman had a history going back more than 5 years. He had intermittent episodes of mono and oligoarthritis, and he used to take SOS NSAIDs and steroid, and he got good relief of that, and so he bothered not to tell these things to his physician, and he was only bothered about a chronic polyarthritis which he was having for 6 months. So now we review the diagnosis. It is not actually rheumatoid, it is chronic tophaceous polyarticular gout. So sometimes patients of gout, long standing gout, almost 10% of them can present as chronic symmetric polyarthritis mimicking rheumatoid, and if you do not take a detailed history or examination, you might miss them. And escalating DMARDs is not going to help. So it's I would not say it's easy to treat, but much more easier to treat than a chronic rheumatoid. Case 4, a middle-aged lady, acute onset joint pains and marked swelling of ankle and feet. She took some drug, probably NSAID, again developed some skin allergy, oral rash, facial erythema. ESR and CRP were high, rheumatoid was borderline, ACPA and ANA negative. She had marked tenderness but no joint swellings. And again she had very marked limitation. You see, acute onset means within 2 weeks she had consulted at least 2 physicians prior to coming to me. And I would just give one diagnostic clue that she was seen in October 2022. So if you remember, if some of you might have encountered, we had a huge pandemic of chikungunya during that year, and sometimes this acute viral polyarthritis can mimic rheumatoid. So sometimes epidemiological background can help you in arriving at correct diagnosis. This is the 5th case, and I will just have one last case. This is a young female, chronic history of 5 years, pain everywhere, off and on swelling. Throughout the day she is having stiffness. All antibodies are positive, ESR, CRP high, there are no extra articular features. And she had consulted several physicians, and also she had undergone treatment from Ayurvedic and homeopathic physicians, and she had only partial relief in any form of treatment. You see, encountered these kind of patients in day-to-day practice. And currently she is on low-dose steroid and also tofacitinib and leflunomide and NSAIDs. Now you look at a history again. So you examine the joints, there are no active synovitis. Probably she is on steroid and tofacitinib, so partially synovitis is controlled. There are no limitation. Why I say limitation? That if patient is, crying in front of you, she is saying that I have pain all day, din bhar mera dard rehta hai. But then you examine the joints, there is no synovitis and there is no limitation. You ask the patient कि कभी ऐसा हुआ है कि सुबह उठ ही नहीं पा रहे हैं आप, या you are not able to do your routine activities, and she says no, then you have to think that whether you are actually dealing with an inflammatory pathology. Active inflammation will always have some limitation. So we took a history again, it was diffuse aches and pains, no synovitis, repeat inflammatory markers were negative. So only abnormality was positive antibodies, but as I said, they cannot confirm the diagnosis. This lady had fibromyalgia. So all treatment was stopped. There were other issues also. She was not able to conceive. There was primary infertility, and probably that added to her anxiety. Sorry. This is the last patient. This one is important. I saw it when in my training days during SGPGI, young male. He had a strong family history of autoimmune rheumatic diseases. 2 of his sisters and his mother were in follow-up in SGPGI. He used to come every time there, and many of the residents and consultants knew him. And one day he started having pains and aches, vague kind of pains. He was seen elsewhere. He was from Indore, and they diagnosed as rheumatoid. He developed skin allergy, ESR CRP mildly elevated, and he had thrombocytopenia. He lost to follow-up, and his skin allergy responded to some extent with homeopathic treatment. Then he had waxing waning kind of pains. And someone diagnosed, some resident wrote in the notebook that he had palindromic rheumatism. I was not the only one, mind you, it's a team. So he was advised methotrexate, but because one of his sisters had problem with methotrexate, he didn't follow up regularly. So 5 months later, he was brought to emergency with sudden unconsciousness. He deteriorated very rapidly. He had young stroke, he had dyspnea, he had probably ARDS and alveolar hemorrhage, and he died within next 48 hours. So I'm not going to the detail that what was his diagnosis, how do we arrive at it. But just a point that if you have some diagnostic uncertainties, nobody ever examined actual synovitis, and just because based on his positive history and his history of vague aches and pains, he was labeled as rheumatoid, and probably that's why we missed some of the clues like skin allergy. As I said, skin allergy due to drugs is common, but it is not the only one. Skin allergy might be primarily due to the disease itself. It might not be allergy. And second thing, that thrombocytopenia should have alerted someone that he might have an alternative diagnosis. Ultimately, post-mortem, he was diagnosed as having catastrophic antiphospholipid syndrome. So just some take-home messages that before ordering any new test, go back to your history and examination, look for extra-articular features, and take opinion from others sometimes. You might be stuck. All chronic pain or polyarthritis is not RA. And rare diagnosis is rare, of course, but if you do not think about it, it will remain rarer. So they are not impossible. And when in doubt, put a query in your diagnosis. Thank you.
Thank you for the wonderful presentation, sir. Sir, although your presentation was quite self-explanatory, but you mentioned chikungunya as a differential. So if you suspect that the patient has a viral arthritis, or in that case chikungunya itself, so how do you manage that? And if chikungunya is negative, how do you approach the diagnosis? Like serology of chikungunya is negative.
So as I said, the most important clue is epidemiology. So if it is an acute onset pain, and if you ask the patient that many other patients in the either in the family or in the neighborhood are also get affected, then your diagnosis is quite certain. Then, as I said, it was typical facial erythema. In one of the studies from Aiims Delhi, they have said that facial erythema is almost pathognomonic of viral arthritis. Coming to how do we diagnose? The first patient, I'm telling you of my own story. In first 4 patients, I did PCR, which was available, but it's quite an expensive test. But after almost a dozen of patients, I was quite sure I did IgM antibody, but the timing of IgM antibody positivity is not very well defined. It might be positive from 2 weeks to up to 6 weeks. So ultimately, the diagnosis is again clinical. If you are seeing an acute onset arthralgia, and most of the time patients will not have obvious synovitis or joint swelling. They will have severe pain, limitation and tenderness, and there is exquisite response to NSAIDs and steroid. So in that setting, acute onset polyarthralgia or even arthritis, the management remains the same, almost the same. I treat all of them with methotrexate. Although the guidelines say you treat with NSAID, then you give steroid, then you give hydroxychloroquine. But we know that this is a self-limiting disease, and by the time HCQS will work, the disease might be over. So with methotrexate, you are able to taper steroid fast. And the main point in making the diagnosis is that you are able to tell the patient that this disease is finite. Maybe by 6 months, all treatment will be over. So I have seen almost only less than 10% of patients who develop chronic arthritis lasting more than 1 year.
Any questions from the audience?
Thank you.
Thank you, sir.
Thank you.
Thank you, sir, for such case-driven approach. May I request our chairpersons to kindly felicitate our speaker, Dr. Kamal Bhatt, sir. To felicitate our chairpersons, may I request Dr. Darab Singh, sir, to felicitate Dr. Rajkumar, sir. And Dr. Rajat Ranka, sir. Our next session explores the evolving utility of ultrasonography in rheumatology. For this session, we have Dr. Sonal Ma'am, Associate Professor, Department of Radiology, Aiims Rishikesh. Please welcome our chairpersons for this session, Dr. Rajendra Srivastav, sir, Professor, Department of Radiology, and Dr. Vishal Thakur, sir, Associate Professor, Department of Radiology from Sri Guru Ram Rai Institute of Health Sciences. We welcome you, ma'am.
Thank you for the kind introduction. Double click karo sir. First of all, I want to thank the organizer for calling me here. And so I'll be speaking for next 10 minutes on the evolving role of ultrasound in rheumatology. So my talk consists of majority, I have ultrasound videos here. So I will be showing those videos and only few slides of text will be there. Okay. So why do we need ultrasound basically? So we are actually moving beyond palpation because we have lot of limitations when we rely on this entirely on the clinical examination alone. As clinical examination is subjective and it often misses deep-seated or early inflammation. Then there is less reliability on patient history and laboratory markers. So subclinical synovitis are basically not sometimes detectable by palpation and we rely on ultrasound for this. So why ultrasound is needed? We need it for seeing subclinical disease. We need it for guiding interventional procedures. And we need them for monitoring treatment response and the treat to target strategy. So ultrasound is a game-changing modality when we talk about rheumatology. Because of its high resolution, the resolution is even better than MR, and it is real time. It allows dynamic assessment of tendons, ligaments, and joints during movement. It has sensitivity to inflammation, so we can use power Doppler to detect hyperemia in the synovium and call it active synovitis. It is radiation-free, it is well-tolerated, and it allows for immediate feedback. We can talk to the patient and ask them which joint he is having more pain, and we can actually see the inflammation in it. It is cost cost effective and accessible, and we can do side-by-side comparison with the asymptomatic side. So now coming on to the imaging that we have. So first talking about rheumatoid arthritis. So as rheumatoid arthritis involves small joints of hand and wrist, this lady actually presented with swelling and tenderness in bilateral wrist joint. And what we can see here is exuberant synovitis. So synovitis will look like hypoechoic thickening coming out of joint, and in this case you can also see increased vascularity on Doppler. So these are two videos which are showing exuberant synovitis arising from the wrist joint with increased Doppler activity. In this case, we can see synovial thickening which is encircling the tendon. So this is tenosynovitis, and again with an increased Doppler activity suggesting active inflammation. So this is acute tenosynovitis. This is tenosynovitis in the long axis view, where we can see the tendons in the long axis surrounded by synovial thickening over here. So this is the flexor tendon of the finger joint, and we can see tenosynovitis over here. Behind that, we can also see synovial thickening in the metacarpophalangeal joint. So this was the case of rheumatoid arthritis, and he had involvement of metacarpophalangeal joint as well as the tendons. Here we can see metacarpophalangeal joint, and the synovial thickening is protruding out from the joint. It is hypoechoic, as all synovial thickening looks like. So there are some grading systems which can be used to grade synovitis. We do them for research purpose, but in routine practice we grade them as mild, moderate, and severe, and sometimes we use term exuberant. So you can grade it like moderate synovitis in the metacarpophalangeal joint. Sometimes patients present with trigger finger. So we have involvement of pulleys. So this is the A1 pulley of the flexor tendon, where we can see thickening of the pulley, and nodule formation is also there. So these are two cases where there is thickening of A1 pulley with nodule formation, and patient had clinical trigger finger. This is involvement of compartment 1 extensor tendon, that is decroinvent tenosynovitis. So here you can see abductor pollicis longus and extensor pollicis brevis. And you can trace them from distal forearm up to the level of wrist, and you can see synovial thickening surrounding it and thickening of the retinaculum. So there is tenosynovitis over here. In late stage, you can see presence of erosion and joint destruction. So here you can see, gross erosions over here in the metacarpophalangeal joint surrounding synovial thickening, and increased vascularity is also here. In this case also you can see destruction of the cortical margins, which suggest erosion and presence of synovial thickening. These are the flexor tendons, and we are tracing them from palm to the wrist, and we are reaching up to the carpal tunnel. So here you can see synovial thickening surrounding the flexor tendons over here. And here you can see increased vascularity in the synovial thickening. So this is carpal tunnel, this is median nerve, these are flexor tendons, and this hypoechoic area is basically synovial thickening. So there is tenosynovitis involving the flexor tendons, and this patient actually presented with features of carpal tunnel syndrome. So carpal tunnel syndrome in this case is because of tenosynovitis causing compression and causing actually mass effect on the median nerve, and it led to carpal tunnel syndrome in this case. In this case, you can see flexor tendons surrounded by synovial thickening and increased vascularity. So this is active tenosynovitis. Moving on to other areas, so we can also have inflammation of bursa. So in this patient, you can see involvement of prepatellar bursa, presence of fluid and synovial thickening over here. So this is a prepatellar region. In this, you can see involvement of olecranon bursa in the elbow region. So there is collection over here and thickening of the wall, frond-like projection inside it, some septa can also be seen. So these are the cases of prepatellar bursitis and olecranon bursitis. Next, moving on to large joints. So here we can see involvement of knee joint. So normally we see a small amount of fluid in the knee joint, which is physiological. But when there is inflammation in the knee joint, we can see large amount of collection over here in the suprapatellar joint recess. So there is gross joint diffusion. Presence of suprapatellar plica can also be seen. In popliteal region, we have this Baker's cyst, which can sometimes get distended when there is joint diffusion because it often communicates with the knee joint. So the location of Baker's cyst, or it is basically a bursa between the tendons of semimembranosus and medial head of gastrocnemius. So when it gets distended, you can see here, so it has a neck and body, so it gets distended and it can sometimes get ruptured and cause calf swelling. So this is a case of popliteal cyst or Baker's cyst. Extensor carpi ulnaris is also very frequently involved in RA. So here you can see ECU tendon surrounded by synovial thickening. And we can also see, erosions in the ulnar styloid process early in cases of RA. Moving on to elbow joint, here we can see involvement of elbow joint, presence of effusion and synovial thickening. And this is the ultrasound video which shows filling of olecranon fossa with synovial thickening and effusion. This is the triceps tendon over here. So there is inflammation in the elbow joint. This is involvement of shoulder joint, involvement of glenohumeral joint. And this synovial thickening has also extended into the biceps tendon sheet, causing mass-like area over here. Because biceps tendon sheet communicates with the shoulder joint, you can find effusion and synovial thickening in the biceps tendon sheet also. A 19-year-old male presented with swelling in the right knee joint. And you can see this radiograph. And this is the ultrasound, which shows effusion in the suprapatellar joint recess and presence of synovitis with Doppler activity. So any guesses? So this is a case of JIA, juvenile idiopathic arthritis, which frequently affects knee joint. This is one such interesting case, a patient of rheumatoid arthritis presented with severe calf swelling. Here you can see distension of bursa, the bursa which I was talking about, Baker's cyst, the bursa between semimembranosus and medial head of gastrocnemius. It got distended and it was completely filled with synovial tissue. So this is pannus formation. You can also see a pointed tip, distal tip, which indicates rupture of Baker's cyst. So this patient actually presented with gross distension of Baker's cyst and filling it with the synovial tissue and rupture of Baker's cyst. Moving on to erosive osteoarthritis, which frequently affects distal interphalangeal joint. So here we can see characteristic radiographic finding over here, which is gull swing sign. So here we can see central erosion and formation of gull swing. And this is the DIP joint where we can see synovial thickening and increased vascularity. So erosive osteoarthritis is basically osteoarthritis but with some inflammatory component. And it affects slightly older age group women and patients present with tenderness in the distal interphalangeal joints. Moving on to gout. So gout is also very common. And any guesses which sign is this that we see in gout? Double contour sign or double line sign. It is because of deposition of urate crystals over the articular cartilage. So this is first metatarsophalangeal joint and this is trochlea in the knee joint where we can see double line. So this is gout. This is another case of gout where we can again see double line sign and the erosion. What is the name of the erosion in gout? Rat bite erosion. So basically these are para-articular erosions and large punched out erosions. And in this case, you can see the erosion is filled with hyperechoic areas which suggest gouty tophus. So this is a case of gout. We can also get ankle joint effusion in cases of gout and other inflammatory arthritis. Ultrasound can also demonstrate floating crystals in cases of crystal arthropathy or gout and sometimes CPPD. So here you can see floating crystals over here in the suprapatellar joint recess. It can also help in aspirating and making available the fluid for analysis. Next, moving on to interventions. So we can use ultrasound for doing lot of interventions in rheumatology. So this patient actually presented with arthritis in the right hip joint, and the joint was very deep. So rheumatologist, they approached us for injecting in the hip joint. And here we can see now how we look at the hip joint on ultrasound. So this is the head of femur, and this is the neck of femur. So here you can see this is the target area where we have to put our needle. And this is the needle, and we gave steroid injection into the hip joint here. This was a case of decroinient tenosynovitis, involvement of first extensor tendon, and the needle was very nicely positioned within the retinaculum, and we injected again steroid in this case. This is a case of a ganglion cyst in the wrist joint, which can present with swelling and limitation of movement. So this ganglion cyst was actually communicating with the wrist joint. So we aspirated it and injected steroid in this case. This is a case of large complex Baker cyst. Again, needle was positioned and aspiration and injection was performed. Some mimics can be seen in cases of rheumatology. So here a case of white hemangioma, which was affecting, periarticular region of knee and also the leg. So here you can see a lot of tortuous vessels. So this was the case of hemangioma, which was involving the knee joint. This is the case of lipoma arborescens, where we get chronic synovitis in the knee joint, and it can also involve other joint, but commonly involves knee joint. And the synovial thickening has characteristic fat deposition. So here you can see fat signal intensity over here. So this is a case of lipoma arborescens. Only one slide left, so I will just talk a few words about advancement in ultrasound technology that can be helpful. First is shear wave elastography. So this is in research purpose. We can use shear wave elastography to assess the stiffness of nerves and tendons, and it can help in early diagnosis and monitoring of the treatment. We can use microvascular imaging, which is an advancement of power Doppler or color Doppler that we normally use. So in microvascular imaging, it removes the clutter and the artifacts, and it actually gives the real vascularity. And third is the contrast enhanced ultrasound. It is slightly costly, so it is not widely used. It is again, it can be used in research purpose and in cases where MRI cannot be done. So that's all from my side. Thank you.
Thank you, Dr. Sonal. It was a nice presentation with good collection of cases.
Thank you, sir.
So take-home message for other specialties is ultrasound is a very good modality and very well accepted by the patient, and you can do multiple joints at the same time. So whatever ma'am has shown, you can very well grade, you can do the follow-up, you can see the response of treatment, you can aspirate for diagnosis. So thanks.
Thank you, sir. So I want to thank my referrers, especially Department of Medicine and Rheumatology, for sending us cases. So thanks to Dr. Pai and his team. Thank you.
Thank you, ma'am, for such a practical session. May I request our chairpersons to kindly felicitate our speaker, Dr. Sonal Saran, ma'am. May I request Dr. Namrata Gaur, ma'am, to felicitate our chairpersons, Dr. Rajendra Srivastav, sir. And Dr. Vishal Thakur, sir. Our next talk brings to us the latest update from the EULAR 2025, What's in the Basket for Rheumatoid Arthritis. This session will highlight new trends, therapies, and research directions in rheumatoid arthritis. We have with us Dr. Rajat Ranka sir, consultant physician at Rheumatology Department from Bikaner as the speaker. And may I request Dr. Kamal Bhatt sir, consultant physician, Department of Rheumatology from Dehradun, and Dr. Akhilesh sir, assistant professor, Department of Medicine, Aiims Rishikesh, to kindly chair the session.
Good morning all, and I'm so glad to be back here at my second home. So today we'll be discussing about EULAR 2025, what's new in the basket for RA. Yeah, so 2025 is coming to a close, so it's an apt topic. So this is my basket for treating RA. As you can see in this basket, I've got the same old conventional synthetic DMARDs, targeted synthetic DMARDs, and biologic DMARDs. CS DMARDs, we have the same four, methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine. Among targeted synthetic DMARDs, we have tofa, baricitinib, upadacitinib, filgotinib, and pefcitinib. Those two haven't been mentioned because they aren't available in India. Then biologic DMARDs, we have the same four classes, TNF inhibitors, IL-6 receptor inhibitors, rituximab, and CTLA-4 Ig fusion protein, that is abatacept. So to address the elephant in the room, there's no new drug in the basket for treating RA, but there are new ways we treat RA. So we'll discuss along these lines. First, we'll see the baseline, where do we stand, what are the last published guidelines. So the last published major guidelines are from EULAR 2022. 2025 guidelines are on the way. So 2022 guidelines are the last guidelines, and they stand on three main principles, that is treat to target, early diagnosis, and shared decision making. So I'll just quickly go through the management algorithms. So you have to make an early diagnosis of rheumatoid arthritis. As Kamal sir pointed out, that you can use the classification criteria to assist your diagnosis, but then again, those classification criteria, you can use the concepts that diagnosis can be made before 6 weeks, and diagnosis does not require X-ray changes. So once you have made the clinical diagnosis of rheumatoid arthritis early, you have to start the patient on methotrexate monotherapy if there is no contraindication. If there are contraindications, then you go for leflunomide or sulfasalazine. Then patients should be combined for a short duration on low-dose glucocorticoids. With short duration, I mean the glucocorticoids should be tapered and stopped in 3 months. So you combine the DMARD with glucocorticoids and reassess at 3 months. If the patient has improved, or if the patient has reached the target at 6 months. So at 3 months, improvement is defined by a 50% reduction in disease activity. If the patient has achieved that, or target is defined by the EULAR 2022 criteria. So if you have reached that, then you continue on the same lines. And if there is sustained remission, sustained means more than 6 months the patient has remained in remission, TJC is 0, SJC is 0, CRP is less than 1, then you can consider a dose reduction. Again, that's not necessary. Then if the patient has not improved, then you look for poor prognostic factors being failure of 2 or more conventional synthetic DMARDs, high seropositivity, especially high disease activity after first CS DMARD failure, or early joint damage. So these are the 4 poor prognostic factors. If they are present, then you consider the patient for a upfront biologic DMARD or a JAK inhibitor. Depending on where you practice, what are the risk factors. Before prescribing a biologic DMARD, you can consider various factors like past history of TB, cost factors are important. Before prescribing a JAK inhibitor, you have to look for thromboembolic risk factors, CVD risk factors. Age more than 65 is a relative contraindication, then heavy smoking is a relative contraindication. Again, reassess at 3 months and 6 months. If the improvement is there, you can continue on the same line. If the patient does not have any poor prognostic factors, we can consider a combination of conventional synthetic DMARDs, which is most commonly we prescribe triple therapy, which is methotrexate, sulfasalazine, and hydroxychloroquine. Then if the patient has not improved with either of the two strategies that we discussed, then we can consider a change in biological DMARD or JAK inhibitors. Usually what we do is, if we usually go to a different class of drug, for example, TNF inhibitors have failed, so we might go to tocilizumab. If tocilizumab have failed, we might go to rituximab. However, they have allowed switch between in between the class if the TNF inhibitors have failed or IL-6 inhibitors have failed. So if adalimumab has failed, you can still go to a different TNF inhibitor as well. Then so these were the EULAR 2022 recommendations. Coming to ACR 2021, American College of Rheumatology's last recommendation is 2021. Then they have clearly stated that you should not give steroids even for a short duration, as long as you are able to manage the disease activity, so they are deferred. Then this is an important thing. If the patient comes to us with a diagnosis of rheumatoid arthritis, patient already has low disease activity, do you treat the patient? Do you not treat the patient? So to that patient, you can give hydroxychloroquine. If then second choice would be sulfasalazine, then methotrexate, and in end you can start the patient on leflunomide. So this is the order of preference. So many times we have patients who have low disease activity at baseline itself. They already have a diagnosis of RA, so we can start them on HCQ. Then this is something different from EULAR 2022, that if a patient has failed a first CS DMARD approach, you directly start the patient on biologic DMARDs or JAK inhibitors. No need to go for a combination of conventional synthetic DMARDs, that is methotrexate, sulfasalazine, or hydroxychloroquine. Patient who are taking triple therapy who wish to discontinue a DMARD, first you take him off sulfasalazine. And last is patient taking methotrexate plus biologic DMARDs who wish to discontinue a DMARD. So we usually discontinue methotrexate, which was already the drug on which the patient had failed. This is also different from what EULAR says. They say that you taper the most expensive DMARD first. Now 2025 guidelines, what they will bring new to the table is that we had discussed that once methotrexate has failed, they tell you to look at poor prognostic factors. So 2025 guidelines say that don't look at poor prognostic factors. If a patient has failed a CS DMARD, that itself is a poor prognostic factor. Go for a JAK inhibitor like tofacitinib or a biologic DMARD straight away. So this is another new guideline that was published this year by EULAR on various aspects of reproduction in rheumatology. So this is very important for us because which drugs are safe in pregnancy, which drugs cannot be given. So they have very clearly, lucidly stated that. So hydroxychloroquine is safe, sulfasalazine, azathioprine, cyclosporin, tacrolimus, colchicine. All the TNF inhibitors are safe in pregnancy. There is a caveat which I will tell. And then NSAIDs are relatively safe, specifically short duration ones like diclofenac and ibuprofen. They are very safe, but you must try to avoid them after 28 weeks because they can lead to premature closure of ductus arteriosus. Then prednisolone and low doses is quite safe. What is not safe, we already know, like cyclophosphamide, mycophenolate, methotrexate, they are a big no-no. Leflunomide we do not give, but there is insufficient data. We usually carry out washouts, or we have a period of 2 years before we can allow the patient to conceive. So once this is important for those who have a special interest in rheumatology, that if the patient has received TNF inhibitors in utero, how do we manage the vaccination schedule of the baby? So if the TNF inhibitor exposure has occurred in the first half of pregnancy, you do not need to modify the vaccination schedule at all. However, if the mother has received adalimumab, golimumab or infliximab after 20 weeks and etanercept after 32 weeks of gestation, then we have to avoid BCG vaccine for the first 6 months because the transplacental transfer occurs in the second half of pregnancy itself. Other non-live vaccines, no modification is required. Regarding other non-TNF inhibitor biologic DMARDs, if the patient has received in the second half of pregnancy, you do not give any live vaccine to the fetus for the first 6 months. Then drugs compatible with breastfeeding. I just want to highlight that this is new in the guidelines. All TNF inhibitors and all biologics are now safe in breastfeeding. You can safely give them. And if the patient is taking prednisolone more than 20 mg, then you just ask the patient to not breastfeed for the next 4 hours after the steroid dose. That will minimize that. Even males who are taking DMARDs, they may give teratogenicity to the fetus. So males who are trying to conceive, we must look at what taking as well. So for example, if the male is taking cyclophosphamide, there are two problems. One is the baby the fetus may develop teratogenicity. Second problem is that cyclophosphamide leads to a irreversible gonadal toxicity in males as well as females. So, but in males, the dose which can cause irreversible damage is significantly less than the dose that can cause damage in females. So, in males, even a dose 4 gram per meter square is dangerous for the future fertility aspect of the male. So, we must ask them to get sperm banking done. Then otherwise, another thing I just want to highlight is sulfasalazine can cause irreversible sterility. Not sterility, reversible damage in the sperm counts, and discontinuation might help with the fertility. This was another, last two slides, this was another consensus statement on treatment with JAK inhibitors. Tofacitinib is now being widely used, very widely used actually. So they have come up with a consensus statement to allow for stricter and safer use of JAK inhibitors. JAK inhibitors should not be given if there is CLD with a CTP score of 9 or more, or EGFR less than 30. Then dose reduction should be considered. Once the patient has reached the target, we can go for a dose reduction to like tofacitinib half dose, and like that it can be tapered. Then risk factors that need to be considered before giving JAK inhibitors are smoking, age more than 65, prior venous thromboembolism, prior CVD, hypertension, diabetes, and dyslipidemia, and prior malignancy. So if there are no such risk factors, you can safely give JAK inhibitors. If there are risk factors but ASCVD score is less than 10%, again you can give. If there are risk factors, ASCVD score is between 10 to 20%, but the patient did not have any previous major adverse cardiovascular event, again you can give. But if the patient has had a major cardiovascular event in the past, or if the ASCVD is more than 20%, you have to avoid JAK inhibitors. And if the patient's age is more than 65, or he has been a smoker or reformed smoker, then you should avoid. Yeah, take home messages are that no new drug for RA in 2025. However, from Indian point of view, upadacitinib is now available. EULAR 2025 guidelines are awaited, but I told you what can be expected in those guidelines. Then we had a consensus statement highlighting stricter and safer use of JAK inhibitors. We have we may now see earlier use of combination with targeted DMARDs because of the new guidelines, and elaborate yet consensus guidelines on the use of anti-rheumatic drugs with respect to reproductive aspects was published this year. So thank you.
Thank you, Dr. Ranka, for a nice presentation on the recent guidelines. And the house is now open for questions. If nobody has a question, I would like to ask one for myself. That it's regarding tofacitinib, because we are seeing more and more use of this drug. It's orally available and quite much more economical than the injectable biologics. So what's your view? Are you using it upfront as a first-line treatment in young patients? And if the patient achieves remission, maybe if you are giving it along with methotrexate and the patient achieves remission, so which of the two would you like to reduce or taper later on?
Sir, so if the patient is young patient, even then I'm never upfront using tofacitinib. I start with methotrexate only, and if I need to add tofacitinib and then the patient achieves a remission and there is a sustained remission of more than 6 months, and the patient is willing for a DMARD taper, all these conditions are met, then I would first try to taper. In a young patient with no risk factors, I would try to taper methotrexate first, because tofacitinib was added second, and it was after adding tofacitinib to a optimized dose of methotrexate that the patient achieved remission. So I'll first taper methotrexate and then go for tofacitinib taper.
Thank you.
Thank you, sir.
Thank you, sir, for that insightful update. May I request our chairpersons to kindly felicitate our speaker, Dr. Rajat Ranka, sir. Our next session highlights a very important and clinically relevant topic, glucocorticoid toxicity index. To shed light on this important topic, we have with us Dr. Kalyani ma'am, Head of Department of Endocrinology, Aiims Rishikesh. This session will be chaired by Dr. Pragya Gupta ma'am, Assistant Professor, Department of Endocrinology, Aiims Rishikesh, and Dr. Mukesh Bhairava sir, Additional Professor, Department of Medicine, Aiims Rishikesh.
So welcome Dr. Kalyani. Dr. Kalyani is heading the Department of Endocrinology, Aiims Rishikesh. Ma'am is widely exposed in diabetes and other endocrine disease. So no need further introduction. Straightforward, ma'am. Over to you.
Hello all, good morning. I thank the Cardiodiabetic Society for giving me this talk. So this is a really important talk. Slide changing or okay, so today I will be talking about the topic that's given to me, which is a glucocorticoid toxicity index. Now this is a specific index and it was recently created to measure the glucocorticoid toxicity. So let me discuss with you what is the rationale for developing this index, what are the domains of this index, and how is the scoring applied, and what are the clinical utility of this index as of now. So again, beginning from background, we all know why you need to assess glucocorticoid toxicity, because glucocorticoids are a cornerstone for several diseases, rheumatological, autoimmune, many diseases, and chronic exposure is known to result in multi-system toxicity, which is a significant part of this therapy. So several attempts are made to try and decrease or avoid toxicity or even measure them. The problem with glucocorticoid toxicity is that it is difficult to measure and it is also difficult to quantify beyond a cumulative dose. So this has limited the development of any such index, any such cumulative or a comprehensive index. So that was the current traditional assessment is only clinical, where we assess the total dose that is being given to the patient, and not always does it correlate with toxicity. Several different patients respond differently, and the assessment of the quantification of toxicity is different. There is a lot of interpatient variability for toxicity as well, and there is no single standardized tools until now. So these were in addition to this. So there was an international group which tried to analyze the glucocorticoid to come up with a glucocorticoid toxicity. So the challenges that they faced while trying to create an index was these. First, in a single instrument cannot capture all the toxicity, because glucocorticoids can affect several organ systems. So for a single instrument to capture all this is going to be difficult. And also the nature of glucocorticoid toxicity can be both acute and chronic. So again, for a single instrument to capture both these types of toxicities is again going to be difficult. Third is that, so several times glucocorticoids have been used even before for a set condition. That is, you use during flare. So patient has already had glucocorticoids before. So if you start analyzing or using a screening instrument at this point in time, there is already a background toxicity which needs to be accounted for. So in addition to this, there is a background rate and attribution. Like if you're assessing about, say, bone toxicity. Now the patient is postmenopausal, he or she will be having an already additional load of toxicity in her. So every patient is different. So this background load of toxicity is going to confound the assessment of further toxicity by the glucocorticoids. Finally, degree of toxicity. Again, different patients, like I said, the severity is not something that can be easily analyzed. So that's one problem. Then variability in patient population, like I said before. Comorbidities. Different patients can have already associated diseases, which can again needs to be accounted for when you're assessing a single index. So all these are several challenges, and these were tried to be addressed in a single expert committee setting, where what they did is they developed a working group, which was called the Omar Act Working Group. They tried to do two things. One is they tried to capture the change in glucocorticoid toxicity over time. So the idea was that once you're starting a steroid in a patient for any indication, over time you try and see how much of toxicity the patient is developing, or if you are trying to develop a drug which will help in reducing this toxicity, how much is the improvement happening in that. So it's a kind of a quantifiable and measurable screening tool for toxicity. And the idea was to develop it for both clinical trials and real-world patient use. So what they did is, after this, this was set up in 2015, 2016, and as a process of development, they developed first domains upon which the glucocorticoid toxicity were assessed. So these domains are something like this. One is a metabolic domain, which is where they assess the BMI using height, weight, then the blood pressure, glucose metabolism, lipid metabolism, bone mineral density, glucocorticoid myopathy, skin toxicity, neuropsychiatric effects, infection. So they classified the entire glucocorticoid toxicity into these 9 domains, and then tried to assess each of the domains using clinical or lab parameters like height, weight, systolic, diastolic blood pressures. If it is a myopathy, they assessed using a proximal muscle estimation, physical examination for proximal muscle weakness, neuropsychiatric effects through a patient interview. So it was a combination of both clinical as well as lab assessment. So as a consequence of this, each of the items were analyzed under each of these domains and then weighted. And the weights were decided depending upon a face-to-face, a Delphi kind of a consensus. Then a scoring was given to each of the items, and then the scores had to be added. Or if it is improving over time, if there's, say, a decrease in BMI, then a negative score was given. So then the scores could be subtracted. So though it reflects both worsening as well as improvement. So if you're looking at worsening, then you would call it a cumulative worsening score. So you have a baseline score, you assess at the start of the glucocorticoids, have an initial score, and then see after starting the steroids, over time, say 3 months or 6 months, you reassess the score and see how much it's worsening. So then you call it a cumulative worsening score. You can also look at an improvement. If there is an improvement over time, that also can be assessed with an aggregate improvement scores. The domains are the same. So this is the way of scoring. So let me show you the screening tool proper. So like I said, this is a BMI. For example, let me take one and explain. So change in BMI, if say on starting the therapy, there is a decrease of more than or equal to 5 BMI, like 5 units, 5 kg per meter square, you decrease the score by 36. Or if there's a decrease by 2 and to less than 5, you decrease the score by 21. No significant change in BMI, there's no change in score. On the other hand, if the BMI has increased, you add the score by 21. So each of these parameters are calculated and given scoring as per this chart. So similarly, you have, like I said, you have parameters for hyperlipidemia, bone mineral density, steroid, myopathy, skin-related toxicity. So you analyze and then you score as per the type of toxicity that you get. So this is the sum of all the 8 scores, and finally you give a last final score, adding up all these scores. So based on that, you then interpret the change over time. If there is an improvement, if you get a positive score, there is an improvement, that means there is a worsening in the overall toxicity. So you can know that this drug or the amount of toxicity in which particular domain it's worsening. So this I've already told you. Now after the initial development in 2015, 2017, there have been several versions of this GTI. So you have the longitudinal version which assesses change. You have a snapshot version as well. you can do it like a cross-sectional and get an idea of what is the domains or domains under which the toxicity is most. Now this is through a licensed GTI app. It's not free to use tool, which is why I could not show you how to. But you have to, if you have this app, you input the patient data and then you get a score. The app gives you the score. So these are the versions available. The current version is 2.0. That's a 2022 version. So these are the validated studies that have used it, and now there are several studies after the initial versions that have used these scores and validated it in several disease conditions. Most of it has been in SLE, vasculitis, myositis, which are rheumatological disease. So on validation studies, it has found to have a good reliability, and it is very sensitive to changes in all those domains over time. So what is the clinical application? So currently we stand at using these tools on a research basis. That is, it is an objective kind of a trial endpoint for steroid-sparing drugs which are being developed for various rheumatological conditions. Like you compare the drug with the steroid, and then you see what is the change in glucocorticoid toxicity index in both the groups. So it's something like a secondary objective. Several trials have used it as a secondary objective. It's not yet widely validated for clinical use, but on a case-to-case basis with a shared decision-making, you can use it to assess the toxicity in an individual clinical case as well. So for example, this is one example where this was a trial which used this agent called avacopan, which was a agent which was used in a rheumatological condition, and they compared it with the prednisone arm. So one of the outcomes in the trial was the GTI score. So as you can see, they compared the change in scores in both the arms and used it as an objective measure to see the change in glucocorticoid harms, to assess glucocorticoid harms in the study group. So this is one use of a GTI, and this is the currently most widely used version of the GTI. So like I said, what do we use it in practice? What we do is baseline before the glucocorticoid therapy, and then it's reassessed after a certain point in time, because the main idea is to assess the change or the accumulation of toxicity or even improvement over time. So, but then it needs a trained evaluator. Someone has to actually understand the app, understand the scoring, and then interpret the scoring. So it needs someone with training to use it. So the strengths are, this is a comprehensive multidimensional tool. It is well validated for several, like I said, for use in clinical trials, and it is very sensitive to changes. So any small changes in each of those domains can also be analyzed. And this is independent of dose, and it is useful for demonstrating the steroid sparing effect. So if you want to actually demonstrate how much improvement or how much the glucocorticoid harm does a steroid sparing drug offer over prednisolone, then this is a good way to do it. But the limitation, like I said, is it requires some time to analyze the whole, the tool, and it requires some training. There are some subjective items, like instance, the neuropsychiatric effects are all subjective. So that can change in patient, or it depends on how you're asking the patient. So that is a little subjective. It's not yet universal because it's a very recent tool. 2022 is the last validated version. And much of the trial have used adult patients, so there's no pediatric data. And it doesn't capture all toxicities. There are domains upon which it has been, these are the most common domains of glucocorticoid toxicity, but there can be other toxicities as well, which obviously are not captured in this. So that's a limitation in this. But there are several upcoming studies which have tried to integrate it with the clinical clinics or the medical record data, where it automatically inputs. Once you start the therapy, it automatically inputs the clinical data onto the platform and then gives you the score right at the beginning of starting the steroid therapy. So it integrates you with the change in scores that you do over time. So again, there are some studies which are currently using it in pediatric and transplant patients as well. And again, it's going towards biomarker prediction. And there are trials which are trying to use it, bring it to a clinical version, which can be used bedside or patient side, because right now we are only using it in clinical trials. So for example, this is just a case example. Like you have a patient who is using prednisolone, say 15 mg for 12 months. Then you document this glucocorticoid toxicity. You find that the patient is having changes in weight. There is a hypertension, mood change. You score all these under individual parameters. You get a score of plus 45. So you understand that now this patient's toxicity is improving, and you also understand under what domains it is improving, and where you improving. What I mean is worsening. So you then understand what are the domains which needs attention or which needs clinical care, or if you need to change the steroid to a steroid sparing agent. So this is how you can use it on a single case-to-case basis. So to summarize, this particular index is a validated measure of glucocorticoid harm. So it complements the dose-based metrics that we use, but cumulative dose doesn't actually translate equally to all toxicities. So it enhances clinical care. It's primarily used for clinical trials. So it's moving towards clinical use as well. Thank you.
Thank you so much, ma'am. So concise topic, and you finish your times. So there is a you shown in one slide that we have to assess baseline then after 6 months.
Yes.
So any tools those patients who require less than 6 months, because we have seen that patient may develop glucotoxicity in 1 month or 2 months.
So actually that initial study said assess in 3 months. So we can choose the assessment point. Like if you're choosing a higher dose of steroid, and if the baseline toxicity, suppose you're getting a baseline score which is higher, then you can choose to assess the patient in 3 months also. So it doesn't fix a time point at which you need to do a follow-up assessment, but it says it can be from 2 to 3 months. So we can assess earlier if you feel the patient is going to develop more toxicity.
Moreover, is a qualitative assessment only?
No, so it is a semi-quantitative kind of thing. Like it quantifies your weight gains, like BMI, change in BMI, and it gives you a weighted score. So whereas a neuropsychiatric thing is a qualitative thing. It just assesses whether a patient is in depressed mood or not and gives a score. So some portions of it are very subjective and qualitative, some are quantitative. But overall it gives you a kind of semi-quantitative scoring.
But those patients who are having already baseline neuropsychiatric illness, suppose patients have SLE,
yes.
that disease itself
Yes. So that is a limitation. That is a limitation. So it can't differentiate from whether this, it's not very specific. Like depending on the kind of weight gain, suppose a patient is taking some other drug which can cause weight gain, it cannot differentiate that. It will still score high on the glucocorticoid toxicity index. So these are limitations of the study, but that is a big problem with assessing glucocorticoid toxicity as well, because several of the toxicity can merge with the underlying disease and the underlying comorbidities. So that is a limitation of this index.
Thank you for the presentation. So I have a question, like when we are giving replacement doses of steroid, there is intra-individual variation. So for some patients it's 5 mg, some patients, can this tool be used for physiological dose replacement also?
So in the validation study that used it, they started with supraphysiological, that is where it was, glucocorticoid was used as a treatment, as a, not as a replacement. So, but if we are talking about glucocorticoid toxicity, then this tool is good at assessing the change over time, rather than a cross-sectional assessment of toxicity. Because when you try to assess cross-sectionally, especially when you're giving on a replacement dose, it might not reflect the glucocorticoid toxicity. It might reflect the underlying disease toxicity. So probably where it can be used is a follow-up over time. But again, this is not typically for a replacement dose. This is mostly for a supraphysiological and a pharmacological dose.
Thanks.
Any question from the audience? No question, we can conclude.
Right. So see, there are two things in this. When you decrease the, first let me answer your DEXA question. DEXA itself is a tool which needs some time for the change to show. So DEXA may not be a very good marker to assess the bone parameter. So in that bone parameter, there are tools other than DEXA. So you will have to probably input those tools. Second thing, even when you're using this GTI, if you're using at very small frequent indices, so they have calculated a minimal clinical difference, that's called MCD for this tool. So even to say that only when it crosses beyond that MCD, that is, say the initial score was 120, the follow-up score in 2 months is 123. So this 3 units is not exactly a significant. So when do you call it a significant increase? When it is 2 standard deviations over the minimal clinical limit. So that MCD, it should cross that MCD. So it will cross only when you assess it at a reasonable time, like at least 3 months, or you're expecting that there's going to be a huge difference. So assessing it at very close intervals will not give you a very good idea. the attributability is going to be difficult. And yes, like you said, especially on bone health, changes in bone, I don't think it makes sense to assess too early, because that itself will take time to come. But yes, this is mostly for other parameters like metabolic things, change in glycemic, where you're expecting that there can be changes within 2 months. So bone, it is not a good clinical thing to, so some things in this are very subjective. It is not, you have to put your clinical judgment and then assess. Mm-hmm. So that is what, 3 months is the minimum they have said. The developers of this tool have said 3 months. But this also is for a clinical trial. The version for the clinical use, bedside use has not come because the interpretation is confounded by several things. But yes, 3 months is what the developers have said.
Any other question from the audience? Okay, in the future, maybe the tool will be modified by adding other biochemical markers.
Correct.
Thank you so much, ma'am.
Thank you.
Thank you so much, ma'am. Now I would like to request our chairpersons to felicitate our speaker. I would also like to request Dr. Mukesh Verva sir to felicitate our chairperson, Dr. Pragya ma'am. Our next session is on bone health and diabetes. For this session, we have Dr. Nisha ma'am, Assistant Professor at Department of Medicine at Aiims Dehradun. I would like to request ma'am to come up on the stage. I would also like to request the chairpersons for this session to come on the stage. Dr. Anisa Mirza ma'am, Professor and Head Department of Biochemistry at Aiims Rishikesh, and Dr. Kalyani ma'am, Head of Department of Endocrinology at Aiims Rishikesh.
Good afternoon, everyone. So thank you, organizing committee, for giving me the opportunity to talk on this important topic. So I'll be discussing about bone health in diabetes mellitus with recent updates in screening and treatment. So let's start with the introduction, why bone health matters in diabetes. The skeleton is being increasingly recognized as a target organ affected by diabetes, currently the term being given as diabetic osteopathy. Both type 1 and type 2 diabetes are associated with a high risk of fractures, despite being the different pathophysiology. Like type 1 diabetes is characterized by reduced BMD and impaired peak bone mass, while on the other side type 2 with normal or increased BMD but with poor bone quality and increased fragility. So how common is the disease? With a diabetic prevalence of more than 500 million people globally, even a small relative risk carries a major absolute fracture burden. And in a recent meta-analysis published in 25 only, there was 34% higher overall fracture risk in patients with diabetes, with hip, pelvis, and vertebral fractures being the most frequent ones. So, and if we talk about our country, this large population-based study conducted in more than 50,000 people revealed a higher fracture risk in diabetes, with the odds ratio of any fracture being 1.28 and low trauma fracture odds ratio being even higher of 1.8. if we compare the fracture risk in type 1 versus type 2 diabetes, what we observe that risk of any fracture is significantly higher in type 1, including both hip and wrist fractures. But for the vertebral fractures, the risk is increased in both type 1 and type 2 diabetes almost equally. And interestingly, this 10-year fracture risk actually remains higher at every BMD level in diabetic population. And the issue is not just the increased fracture risk, but the fracture outcomes are even poorer in diabetic patients in terms of delayed healing, more frequent infections, and increased mortality. So what drives these skeletal changes in diabetes? Well, the pathophysiology is multifactorial, including metabolic, hormonal, and the microvascular derangements. Type 1 diabetes mellitus, which is characterized by the insulin deficiency, there is predominantly impaired osteoblastogenesis and the low bone turnover, while type 2 diabetes mellitus, it is chronic hyperinsulinemia and the insulin resistance, which leads to altered bone remodeling and the increased cortical porosity. So for type 1 diabetes, we see that insulin primarily has got a dual role. It not only just leads to maturation of mature osteoblast from its precursor, but also impairs the osteoblast apoptosis. So in the presence of insulin deficiency, this whole process is disturbed, leading to impaired osteoblastogenesis. And for the type 2 diabetes mellitus, it is completely a different story. Because of chronic hyperglycemia and insulin resistance, there is accumulation of advanced glycated end products, which leads to abnormal collagen cross-linking, also inhibits the osteoid mineralization, and alters the rank and rank ligand pathway, leading to increased osteoclastogenesis, ultimately leading to bone fragility. And in addition to these primary pathophysiological mechanisms, there are additional modulators of bone fragility in both types of diabetes, like hypogonadism, which is as prevalent as 30% of the type 2 diabetic patients. In addition to that, there is vitamin D deficiency, presence of microvascular complications, diabetic retinopathy, which can lead to impaired vision and increased falls, leading to higher fracture rates, sarcopenia, increased bone marrow adiposity, and the calcium and magnesium imbalance, which is frequently encountered in diabetic patients. And when we discuss about this, we should not forget about effects of anti-diabetic medications per se on the fracture risk. There are certain medications like thiazolidinediones, sulfonylureas, which have been found to increase the fracture risk rates. And for SGLT2 inhibitors, canagliflozin has also been found to be associated with higher fracture risk. Insulin, although seems to improve the bone formation, but in the advanced diabetic cases, it leads to frequent hypoglycemia, which can lead to increased falls and fracture rates. GLP-1 receptor agonists, on the contrary, have been found to reduce the fracture risk in diabetic patients. So, how do we detect diabetic bone disease? There are certain diagnostic tools which can be used. Bone densitometry, fracture risk scores, bone turnover markers, and some advanced tools I'll be discussing. So DEXA is traditionally used for the diagnosis of osteoporosis, which measures aerial BMD primarily at hip, spine, and forearm. But for the type 1 diabetes mellitus, studies have consistently shown reduced BMD in type 1 diabetic patients as compared to the healthy controls. But for the type 2 diabetic patients, there is a heterogeneity in the data, and they are characteristically found to have either normal or a slightly higher BMD as compared to the normal population. So, DEXA basically fails to reflect the bone quality, and it underestimates the fracture risk in diabetic patients. So we have to interpret the T-scores with caution, and here comes the role of FRAX-based adjustment. So what is FRAX? FRAX is basically a fracture risk assessment tool which takes into account multiple factors and tells us the 10-year probability of major osteoporotic fracture and the hip fracture in patients. But again, it is applicable only to those people who are more than 40 years of age. And if we see at these parameters, they have not incorporated diabetes mellitus as one of the risk factors. So it again needs to be adjusted for the diabetic patients. So what are the adjustments that we can make for the FRAX assessment? Either we can increase the age of the patient by 10 years. We can add rheumatoid arthritis as one of the risk criteria. Or we can reduce the femoral neck T-score by 0.5 SD. Or we can use the trabecular bone score based FRAX adjustments. So what is trabecular bone score? As we have discussed the limitations of BMD and the FRAX score, trabecular bone score is nothing but it is a special computer software derived algorithm. It uses a special computer software based algorithm which basically tells you about the quality of the trabecular microarchitecture. It is obtained mainly from the DEXA-based spinal images. So this is the well-structured trabecular bone. On the other side, here we can see the altered trabecular bone patterns. It has been found to be associated with HbA1c and links the bone architecture and glucose metabolism and is found to be quite superior to BMD in predicting the fracture risk. And the interpretation, basically it calculates the average TBS value from L1 to L4 with values more than or equal to 1.35 being normal and less than 1.2 being degraded microarchitecture. I'll explain with giving you an example for this. These are the DEXA images of two patients. Both have found to have a T-score of minus 2.2. But if we see at the trabecular bone architecture, here it seems to be normal, but it is quite degraded, giving us a TBS score of 1.4 in this case and 1.059 in the below case. So it tells us that where it can be useful for us, especially in the diabetic patients, where we usually, type 2 diabetic patients, where we get the falsely higher T values. There are other advanced imaging tools for the osteoporosis detection, like high-resolution peripheral quantitative CT scan, or the QCT, or the ultrasound. But these are not much validated in diabetic population and still in the research phase. Besides imaging, there are biochemical markers as well which can give us insights into the bone metabolism. These are bone turnover markers which actually reflect short-term changes in the bone remodeling. They are not used for the diagnosis of osteoporosis, but they can help us in monitoring the patients on the treatment or can be used as the research tools. So as per the International Osteoporosis Foundation, the two markers are used for the bone formation. We use P1NP, and the for bone resorption marker, CTX is primarily used. So, and if we talk about diabetes, diabetes is predominantly a state of low bone turnover, characterized by low markers of bone formation as well as low markers of bone resorption. And these bone turnover markers usually do not correlate strongly with BMD in diabetic, although it has been found that low osteocalcin and low P1NP are linked to high fracture risk rates in diabetic. So again, the role is still evolving. They are not diagnostic per se, but can be used for the monitoring the effects of anti-osteoporotic treatments, or they can be used again as a research tool, as I discussed already. So how do we manage the bone health in diabetes? Let's look at the recommendations for screening as well as the treatment. So as per the ADA recommendations, assess the fracture risk in older adults with diabetes as a part of routine care in the diabetic clinical practice. DEXA, although be having certain limitation, but still it is recommended as the initial tool for the BMD assessment. So what are the candidates for the BMD testing? People who are more than 65 years of age, or the postmenopausal females and men more than 50 years of age with at least one diabetes-specific risk factor, like frequent hypoglycemic events, diabetic duration more than 10 years, HbA1c of more than 10%, patients on certain medications like insulin, sulfonylurea, or thiazolidinediones, the patients with microvascular complications or history of frequent falls, or those who are on glucocorticoids as well. So because of the limitations of DEXA, we have to incorporate FRAX-based adjustments, as well as TBS or HRPQ-CT can be used if these are available with us. And the vertebral fracture risk assessment or the X-ray spine, this should also be done predominantly those who are more than 70 years of age or when we are suspecting a vertebral fracture. But What about type 1 diabetes? As we have discussed, type 1 diabetes is also found to have significantly higher risk of fractures, but still the guidelines are not clear about the regular assessment. Well, it can be considered in those with coexisting diseases like celiac disease or hypogonadism. Now let's move to the treatment principles. The general management principles optimize the glycemic control while avoiding hypoglycemia and falls. So there is no clear-cut HbA1c target, but it has to be individualized considering the other risk factors as well. Avoid the medications with a higher fracture risk. Ensure adequate calcium intake, that is 1000 to 1200 mg per day, with a vitamin D intake to maintain the levels at least more than 20 nanogram per ml. And certain lifestyle interventions like weight bearing or resistance exercises, avoid smoking and alcohol, and incorporate fall prevention strategies in those who are at high risk. So, what are the indications of pharmacological therapy? Whom to treat and how to treat? Well, the anti-osteoporotic therapies are recommended in those with a T-score of less than or equivalent to -2. This is different from the recommendations which are applicable to the normal population, where we treat at a T-score of -2.5. Or those with a history of fragility fracture irrespective of the T-scores, or the FRAX-based risk score of more than 3% of hip fracture and 20% of major osteoporotic fracture. What should be the choice of pharmacological therapy? I mean, anti-resorptive treatment or anabolic treatment? There are no clear-cut recommendations, but we can see with anti-resorptive therapy, we have an ample amount of data which tells that they are effective in preventing the fracture risk. But if we remember, we have discussed diabetes is a state of low bone turnover. So it can again suppress the already low bone turnover state. So it should be cautiously used in long-standing diabetic patients. For now, these are suitable for the moderate fracture risk and maintenance after anabolic therapy. While for the anabolic therapies, there are certain advantages that they improve the trabecular structure and the microarchitecture. For now, they are recommended to be given in those with a history of fracture or those with severe osteoporosis with a T-score of less than -3.5. And here denosumab deserves a special attention because of the recent studies that have told that denosumab has not just been found to be effective for the osteoporosis, but also found to be helpful in reducing the insulin resistance. So there are dual bone and metabolic benefits, and it need to be considered. And as we are frequently talking about this new molecule GLP-1 agonist, they are also found to be helpful in preventing the fracture risk. Certain meta-analysis as well as a real-world study has also showed that they are associated with a reduced risk of osteoporosis. In addition to these, there are certain emerging molecular mediators which are, could be the potential molecules for the future therapies. So in the end, to conclude, diabetes mellitus significantly compromises the bone strength. It is primarily a state of low bone turnover and the altered microarchitecture. Comprehensive screening is required, which includes DEXA, FRAX, TBS, or HRPQCT. ADA 25 emphasizes the routine bone risk assessment in the diabetic patients. Anti-resorptive and the anabolic therapies both remain effective and need to be individualized. And there is emerging evidence of agents like denosumab and the GLP-1 agonist. Thank you.
Thank you, Dr. Nisha, for elaborately covering the topic, and it is again very important because diabetic osteopathy is not much spoken by this, but you have highlighted all the points and covered all the points, and very important topic because skeletal system on which the whole human body stands, yes, so we cannot neglect it. So, and diabetes is very common, so we have to take care, and I think Dr.
So hi Nisha, good presentation. You really covered everything. So the thing, again in addition to what, just to add to what you were telling, again in diabetes patients, in addition to the anti-glycemic therapy, we use PPIs quite a lot.
Oh, yes.
That is again, that can add to the risk. Then you talked about canagliflozin. That is a drug effect or a class effect? I think it's a drug effect.
It's a drug effect more of because it has not been found in other studies like with AMPA or dapagliflozin.
Correct.
So,
right. And this point about, that is interesting, the point about denosumab and the glycemic, that point was interesting to me. So good. Any questions? The session is open to the house.
So good, Dr. Nisha. Although typically the thiazolidine ions have been implicated as not bone friendly at least, and also sulfonylureas, but there is no detailed study on SGLT2 inhibitors. What is happening to them? Because by mechanism of action, you expect that there is more glycosuria, there is more calciuria, maybe. How does it?
SGLT2 inhibitors.
Yeah. So how does it fare?
Actually, there are multiple hypotheses. One, they have given, they primarily have told the fact that it basically leads to a state of dehydration, or it can lead to, which can lead to basically frequent falls. So they have just postulated that it could be the mechanism of increased fracture. Because per se they have not studied as such bone BMD or the bone microarchitecture in these cases.
Actually, if you go by the pathophysiology of diabetic osteopathy, it is basically glycosuria which is more culprit. More glycosuria means more calciuria and many more.
This was the second point I was coming to.
Yeah,
That
so
altered calcium balance also they have postulated as one of the mechanisms.
One of the mechanisms.
But the most implicated is the frequent falls because of this.
Okay.
And the second is calcium dysregulation.
Thank you.
Dr. Nisha, congratulations for the wonderful talk.
Thank you.
And we are focusing much about the pharmacological therapy as we concern the bone strength. But we are not talking about the non-pharmacological therapy. I think the weight-bearing exercise, they are equally important as the pharmacological therapy. So we should, they are more important. Weight-bearing exercise, they are very important.
Yes, ma'am.
So, thank you.
Thank you.
Thank you so much, ma'am. I now request our chairpersons to kindly felicitate our speaker, Dr. Nisha, ma'am. Now I kindly request Dr. Prakash sir to kindly felicitate our chairpersons for this session. Dr. Anisa Mirza ma'am. Dr. Kalyani ma'am. Our next session is on antifibrotics in systemic autoimmune-related interstitial lung diseases. We have with us Dr. Prakhar Sharma sir, Additional Professor at Department of Pulmonary Medicine, Aims Rishikesh, to share his insights on this topic. I would also like to invite chairpersons for this session, Dr. R.K. Bharadwaj sir, Consultant Physician at Rishikesh, Dr. Akhilesh sir, Assistant Professor at Department of Medicine, Aims Rishikesh, and Dr. Darab Singh sir, Assistant Professor, Department of Medicine, Aims Rishikesh.
This can move with the click now. With this one as well. It's not. Through this. Okay. Shall I start? Okay. First of all, I would like to thank the organizers, especially Professor Ravikant sir and Dr. Mukesh Berwa, for inviting me to deliver a lecture on actually a very difficult topic, that is antifibrotics in SARD-ILD. Why I say so? Because as a disclaimer, I would like to say that you might be expecting a crisp response that when and when not to start the antifibrotics, but actually there has not been a crisp answer to that yet, and maybe we'll have it in the future. So let's go through it. So when we talk about interstitial lung disease, what we know is it's a cluster of approximately 200 and more diseases that affect the lungs. And while earlier it was labeled as interstitial lung disease and had been classified into several groups based upon whether it was exposure related or whether it was associated with some granulomatous diseases or connective tissue, or it could be idiopathic as well. Recently, the classification changed in 2025 and has been now labeled as having the interstitial pattern or involving the alveoli, or it could be a combination of these. And then there's also a set of unclassifiable ILD. Now, if we talk specifically about the autoimmune disease-related ILDs, what we know is that autoimmune diseases are the systemic diseases. And ILD per se is just a manifestation or an extra-articular manifestation of these autoimmune diseases. And the prevalence is high. It's approximately 40% with systemic sclerosis and RA, that is rheumatoid arthritis, being on the top. And there's a huge variability. Now, this variability could be due to underreporting. We are not diagnosing it well, maybe, or a late reporting. And if we look at the table, what we again see is that RA, that is rheumatoid arthritis, associated with fibrotic ILDs in 40% of the cases, followed by systemic sclerosis, and so on. Now, briefly, I would like to go through the pathophysiology of the fibrosis, because by fibrosis, we actually mean healing. But what happens is, if it's a well-controlled and self-sustained healing, that is fibrosis, it's good for the body. But if this turns into a self or spontaneously progressing type, it turns into a havoc. And that is what might happen in any form of interstitial lung disease with fibrotic ILD, or even in systemic autoimmune rheumatoid disease associated ILD. So what we need to understand is the trigger which initiated the fibrosis might be different among various different ILDs. However, the final convergence pathway, once it turns towards a fibrotic state, it has been found to be a similar disease as idiopathic pulmonary fibrosis, or the IPF, which was actually the most important fibrotic interstitial lung disease which we had known so far. Now, these are the various radiological patterns that we might observe in our autoimmune disease associated ILDs. The first one, if we see, is a NSIP pattern. So what we see usually is some amount of inflammation and some amount of fibrosis. Now, why I say fibrosis? Because this inflammation is not alone inflammation. It is inflammatory fibrosis which is associated. And whether or not it would turn into a fibrotic ILD depends upon how well we can control this. Then the second one is our usual interstitial pneumonia. The third one is a mixture of NSIP and UIP pattern. Then we may have an OP pattern on the left and cystic lung diseases. A very brief about the histopathology. Why I'm boring you with all this radiology and histopathology is because we, in the next few slides, we'll come to know what's actually happening, whether it's a fibrotic interstitial lung disease per se, or whether it's going to progress in itself. So when we talk about NSIP, basically it's infiltration of the interstitium with inflammatory cells, with some amount of fibrosis, as we had already said, but the lung architecture is preserved. The UIP, the classical fibrotic ILD, is associated with fibroblastic foci. And these fibroblastic foci are the things which basically keep on progressing the fibrosis despite removal or having taken care of the initial trigger. So that is what we need to understand. Now, is fibrosis then different in autoimmune disease-related ILDs? Maybe not. But if we look into the histopathological characteristics, because fibrosis, how do we see it? I'll let you know in a while. But if we talk about how it may be different, that from the other ILDs is that there may be less infiltration of the cells, marked infiltration of the cells with lymphoplasmacytic foci and less of fibroblastic foci. So when I say that there is less of fibroblastic foci, what we need to understand is that it may or may not progress towards a progressive interstitial fibrosis. Now, fibrosis is again a broad term, has been classified as fibrotic ILD, or it can be progressive. We are less worried about fibrotic, we are more worried about the progressive, because if it turns progressive, maybe we do not have a particular treatment for that. So with fibrosis, it's actually detected on either histopathology or based on the radiology as depicted in the slide. While in progression, the same fibrosis that had happened starts incrementing despite taking care of the underlying disease. So there have been various criteria that have been applied for defining progression, and one of the most important tools that we utilize is a drop or decline in the forced vital capacity of the lungs. So earlier inbuilt trial gave us a very wonderful criteria for defining progressive fibrosing ILD, and later on in 2022, a new criteria has been proposed, again utilizing either worsening in your respiratory symptoms or your radiology or a drop in forced vital capacity that is looked into via spirometry. And you need to have a combination of these. Now, when we talk about the spectrum of progressive pulmonary fibrosis, that is PPF, if we see very closely, systemic sclerosis and RA have a huge propensity to go into a progressive fibrotic disease. Now, if we have a sense of that the disease might progress, then we also need to understand that there might be certain risk factors, because not all patients would actually progress. But there are certain risk factors. The maximum number of studies have been actually done on systemic sclerosis and then on rheumatoid arthritis. And what they have shown us is that if the underlying lung is already too weak in a patient, that means FVC and DLCO are already too low. If the patient is still a smoker, if the patient is old aged, now these cumulative risk factors might cause his disease to progress despite management of the underlying autoimmune disease. So now coming to the primary question of this topic. Antifibrotics upfront, or do we have to wait, or we have to combine them? Next question would be, which antifibrotic? Because typically what we know about is two antifibrotics, nintedanib and pirfenidone, and what's in the future for us. So now it's going to mix up. So whether we need to add upfront or have to add on after a waiting period. So one of the most wonderful study, the census trial, published in NEGM in 2019, they conducted RCT on systemic sclerosis patients, and these were not progressive disease patients. These were systemic sclerosis patients, and they took approximately more than 500 patients and tried to see over 52 weeks, that is a year, what would be the decline in FVC if we give placebo or if we give an antifibrotic nintedanib. What they found was, if we look at the top left, the mean difference of decline in FVC was quite less in the antifibrotic group compared to the placebo group. The mean difference was approximately 41 ml. And based on these studies and few more post hoc analysis, the American Thoracic Society, under the guidance of Professor Ganesh Raghu, they tried to generate an evidence. They looked at the census trial, a post hoc analysis of the census trial, and the limited number of patients from the inbuilt trial, which I'll show you in the next few slides. And they came up with the conclusion that in systemic sclerosis per se, adding antifibrotic reduces the risk of decline as well as reduces decline. These are two different things, risk as well as immediate decline. And they gave a recommendation that in systemic sclerosis, especially in patients with the risk factors that we just saw on the table, antifibrotic may be antifibrotic may be added as upfront along with the immunosuppressive therapy that the patient must receive, mostly mycophenolate. So this is an Indian study from PGI group, and they tried to see whether pirfenidone can perform as well compared to, as well as nintedanib. So what they did was they give pirfenidone and compared it with a placebo in systemic sclerosis patient, but the number of patients in this study was quite less, approximately less than 40, and they could not find any major difference. But this was an underpowered study, so we cannot make our judgment based on this. Now, coming to the overall systemic autoimmune rheumatoid disease, ILDs. So this is the famous inbuilt trial. What it tried to see, the first one, the census trial, was on systemic sclerosis, non-progressive patients, just fibrotic ILD. This one is on the progressive fibrosing ILD, defined based on the inbuilt criteria that we earlier saw. And what they, again, they compared between nintedanib versus placebo over a duration of 52 weeks. And if we can see the way the graphs are separating, in the antifibrotic group, be it your UIP pattern, be it non-UIP pattern, there's a huge difference, there's a huge gap between the two slopes, proving that antifibrotic added to the add-on, added to the immunosuppressive therapy does make a difference and prevents the decline in lung function. This was basically nintedanib role in rheumatoid arthritis. So this group, what they did was they took the inbuilt criteria, inbuilt data, chose only the patients with rheumatoid arthritis and tried to see whether, apart from the cumulative difference, specifically in RA patient, can adding antifibrotic make a difference. And what they found was that there were only 89 patients and the decline was reduced. And this decline predominantly started happening around 24 weeks. So they thought that this is the amount of time, that is 24 weeks, is the time around which the actual action of your immunosuppressants as well as your antifibrotic begins. I'll just take 2-3 minutes more. Then further studies looked into the safety and tolerability of this pirfenidone in rheumatoid arthritis and again found that this is a trail trial and we can see the various slopes and the difference between the antifibrotic and the non-antifibrotic group, and it does make a difference. So this is the relief trial, again showing the same difference. Based on this, in 2023, the ACR and the CHEST guideline recommended that in patients of systemic sclerosis, you can add antifibrotic as a first-line ILD treatment over the immunosuppressant. In RA-ILD, could not come to a conclusion. In all the other ILDs, they advised against adding as a upfront therapy. If the disease progresses based upon the criteria that we saw, yes, you can add it. So which antifibrotic agent? Both are good. There are two earlier, nintedanib and pirfenidone. Based upon the adverse event profile, you may choose one over the other. While nintedanib is associated with more of diarrhea, pirfenidone is associated with nausea and vomiting. Most of the adverse events are mostly gastrointestinal. So what's in the future for us? A newer drug, nerandomilast, has been recently published in NEJM again. And this was a trial in a patients who were receiving nintedanib or pirfenidone already and yet were progressing. And this drug was added, and it was found that now in patients who are already receiving an antifibrotic and yet your lung decline is progressive, this drug again makes a difference. So coming to almost the last slides, this is what we need. We need more studies. We need more studies from India as well because it's about the behavior of the disease. The disease has a different behavior in different continents, different set of patients. And this would be my take-home message. For systemic sclerosis, yes, you can add up antifibrotic upfront. For any other ILD, you prefer to wait till the disease progresses, or if there is overaged patient with an excessive amount of disease where you may add on antifibrotic as an upfront. These are a few of my references. Thank you.
Very nice topic.
Thank you, Dr. Darab.
Very nice talk. Very nice talk, Dr. Prakash Sarma.
Thank you, Dr. Darab.
Antifibrotic therapy is advised in case of the ILD caused by the autoimmune disease.
Right.
What is your opinion when ILD caused by the infective disease?
ILD is caused by?
Infection.
Okay.
In these cases, antifibrotic therapy should be added or not? What is your
So,
experience?
That's a nice question, and how I would like to answer is that, now, what we are actually talking about is the fibrosis. And fibrosis is a sign of healing. So what we need to understand is healing is a natural process. If we get a cut, it heals. It heals with fibrosis. Same with lungs. So with infections or even with ARDS, you must have seen a lot of patients with ARDS developing some amount of fibrosis. Now, whether or not this would progress is the answer to the question whether an antifibrotic should be added upfront or not. So to answer your question right away, I would say I won't attempt to add antifibrotic right away into these patients if they have developed fibrosis. However, these patients need to be monitored. Monitored how? Radiologically, clinically, spirometrically, to see whether this fibrosis is incrementing, because as we discussed during this talk that the trigger might be the same, but this trigger, even after having removed, may cause a self-perpetuating fibrosis, depending upon the fibroblasts and the cytokines that are associated with it. So if the disease is progressing, add antifibrotic. If it isn't, avoid.
Thank you. Any question from the audience?
I was not hoping to answer your question, Rajat. I'm afraid of you. I guess, Dr. Rajat, our answer would still remain the same. If there's a lot of GGO, that gives us a hint that there's some inflammation ongoing. Now, this inflammation is fibrotic as well, based upon how much reticulations that we can see. We may even find that there's some amount of UIP pattern which has developed into these lungs. Now, we are really afraid of UIP pattern. But as we talked, these diseases behave very differently between different patients as well. So I like to go ahead with immunosuppression to reduce this inflammation and see whether the fibrosis that is left behind, it would ultimately progress in the future or not. So how we do it? We do it by every 3 monthly follow-up of these patients in our OPD, 6 monthly to yearly. We prefer not to go for a repeat CT scan prior to an year. So annual CT to see whether this fibrosis is incrementing, and this is done over in a very rigorous way over the first 2 years, and then subsequently over the next 5 years, because what has been seen is that most of these diseases, if they wish to progress, it's not absolutely 100%, but usually progress over a range of 5 years, mostly in the first 2 years. No. Once you have started, you continue with that. Minimum 2 years of antifibrotic, once you have given to a patient, you may attempt to withhold it, but then again, closely watching the patient that once you have stopped it, whether it's restarting to progress or not. That's it.
What is the
Yes,
incidence of ILD here in Uttarakhand?
Ma'am, we did I can't say the incidence, with the patients that have been
The
coming.
frequency that you see in your OPD?
It's a lot, ma'am. It's a hidden disease. We did a registry program recently, and over 2 years, with the data, actual collective complete data, we had approximately 300 patients
In 2
over
years?
2 years. And this is excluding those patients for which we had some missing data which we could not actually include into our study. So it's
And
really
this is
a
only
burden.
Aims data, so I'm
Yes,
sure
ma'am.
other hospitals
This
also
is
have
Aims and Jolly Grant, ma'am, and our few centers from the Dehradun as well.
Okay.
Yes, ma'am.
Thank
Yeah. Thank you, sir. We'll conclude the session. Thank you.
Sure. Thank you so much. Thank you.
Thank you so much, sir. I now request our chairpersons to kindly felicitate our speaker, Dr. Prakash Sharma, sir. Thank you so much, sir. Our last session is on diabetic peripheral neuropathy from bench to bedside. We have with us Dr. Sandeep Suri, sir, senior diabetologist and consultant physician from ISAR, to share his insights on this topic. This session will be chaired by Dr. Rajkumar, sir, associate professor and HOD, PMR, Aiims Rishikesh, and Dr. S.P. Gupta, sir, senior physician from Kashipur.
Should I start? Okay. Thank you. So, good evening, friends. At the outset, I must thank Dr. Ravikant for bringing me here. I'm just coming from Amritsar. DFSC Con is going on. And that is Diabetic Food Society of India conference that is going on. So, how to change the slides? Okay. This. So, diabetic neuropathy and foot, coming from heart, kidneys, bones, now coming to our feet. I think the approach should be different. First, you have to examine the feet of every diabetic patient. Then examine other system. Because if you miss the feet and the footwear, going to be a catastrophe. As the number of patients with diabetes are increasing, no need to go with the stats. You can just see the peripheral neuropathy. Half of them are going to develop peripheral neuropathy. Also, the prevalence of neuropathy increases as duration of diabetes increase, as other complications of diabetes increase, micro and macrovascular complications. And overall prevalence in Indian scenario is roughly around 30%. We all know why a diabetic foot ulcerate. We can say it's a peripheral neuropathy, there is vasculopathy, there is deformity, there is callus formation, there is decreased blood supply, there is biomechanical defect that leads to ulceration. But issue is that why we require this type of lecture or this type of program. 77% people with diabetes have never heard the word like nerve damage. We talk a lot about cardiovascular disease because morbidity and mortality also related to ASCVD, that is very clear. We talk about CKD also, we talk about cardiometabolic syndrome also, but cardiorenal metabolic syndrome, but we never talk about the footwear. We never talk about the foot care of the patients, never talk about the nerve damage, diabetic foot ulcer, footwear advice, foot care advice in their lifetime. If you talk about ulcers, 35% purely neuropathic, purely, but 50% are neuroischemic. That means if you club them together, 85% of these patients will be having underlying neuropathy. I am yet to see a patient of diabetes without neuropathy getting into ulceration. Whatever may be the biomechanical defect, whatever may be the deformity, whatever may be the PIBD, but neuropathy has to be associated because that makes very clear sense. Your feet are just insensate to even simple trivial injury. So I am going to talk about diabetic neuropathy, basic anatomy, clinical presentation, examination, and certain bit of management. So what is diabetic neuropathy? The presence of symptoms and signs of peripheral nerve damage, dysfunction in people with diabetes after exclusion of other causes. So this last line is very important. You have to exclude other causes. It can be B12 associated deficiency, it can be hypothyroidism, it can be uremia, it can be any vasculitis or autoimmune disease, anything can be a confounder. It can be presenting combined with DSPN. Again, diabetic peripheral neuropathy can involve everything in your nervous system. right from your central, right, also in the peripheral nervous system, preganglionic roots, dorsal root ganglion, postganglionic roots, plexus, trunks, single or multiple nerve fiber. Everything can be involved, everything. So it's a diagnosis of exclusion. 50% of diabetic peripheral neuropathy may be just asymptomatic until you find an ulcer developing. Callus, you will be missing. If you don't do this habit of examining feet of your patients of diabetes, you are not managing diabetes. You are not managing diabetes. So this is an integral part of comprehensive care of diabetes. Very, very important statement I am going to give you. So those who are sitting, those are the postgraduates, undergraduates, make it a habit of a patient of diabetes to look at their feet, to look at their footwear. Ask about the symptom of neuropathy. Then prevalence of neuropathy increases as the patient grows on. Simple to understand. Also, prevalence increases as the duration of diabetes increases. Also, important to remember, it is not only the glycemic control, the glycemic variability has got a direct implication, increasing painful neuropathy, more chances of developing painful neuropathy, more worsening of vibration perception threshold, more worsening of small fiber neuropathy, more development of autonomic neuropathy. So variations are also important. So we are gone away from only quantitative assessment of glycemia. We are talking about now qualitative control of glycemia. Variations helps to come down. So there can be multiple risk factor, can be modifiable risk factor like glycemic control is important, hypertension, dyslipidemia, smoking. So all those complications, all those risk factors for ASCVD, they have got direct implications for development of diabetic peripheral neuropathy. So right from your pre-diabetes, right from your metabolic syndrome state, your patient can develop symptoms, signs of peripheral neuropathy. Don't wait for the diabetes diagnosis. Those some around 10-15% of patients, even in the state of pre-diabetes, they develop all symptoms, all signs of diabetic neuropathy. Coming to basic anatomy, everything known to you. This is cell body, dendrites, axon, myelin sheath. This is the longitudinal cut section. This is the transverse section. But what is more important, a diabetic neuropathy is a diabetic microangiopathy. Why we should call it? It's very important to understand. The blood supply to the nerves is through vasa nervosa. It's highly vulnerable. Least collateral supply, least collateral. Poorest capillary network, no anastomosis in between, directly venules, arterioles communicating. Then poor anastomosis, poorest connective tissue support, and high hemodynamic alteration. You can see how sympathetic nervous system is intermingling with all these vasa nervosa. And there is marked AV shunting. That means even without arteriosclerosis, even without atherosclerosis, you can develop microangiopathy. So there is a direct shunting of blood from arterioles to venules, and the nerve fiber, which is inside the endoneurium, will be deprived of the blood supply. This is typical of arteriosclerotic changes. But you can develop microangiopathy, you can develop microvascular complications, neuropathy associated, even when you have got well palpable dorsalis pedis, even when you have got well palpable posterior tibial. What to talk about the proximal arteries? There are two types of nerve fibers, everybody knows here, modulated or myelinated and non-modulated nerve fiber. Only thing, the nerve conduction is different in modulated. It is saltatory conduction, and the nerve conduction, it jumps from one node of Ranvier to another node of Ranvier for the fast conduction. Important thing, this combination, myelin sheath, Schwann cells and axon relationship is very, very important. Myelin sheath provides insulination, physical support, nutrient supply to axon, neurotropic factors to axons, and very important line, it's a mitochondria, which are they are loaded in the myelin sheath and they supply ATP to the axon. Nodes of Ranvier, why it is important? Because they are having lot of mitochondria and they have got maximum concentration of ion channel, sodium channels. They are predominantly there at nodes of Ranvier, and where you use various drugs to treat symptoms of neuropathy. So again, important thing, the sensory nerve fiber. I am only talking about those things which are very important, clinically relevant. Sensory neurons and their receptors, they are outside the blood-brain barrier. So that's why they are picked up earlier. Then comes your motor neurons, which are there in the blood-brain barrier, so they will be picked up later. So patient can have lot of symptom without signs, without any muscular atrophy, without any gait abnormality, and tendon jerks can be normal. Pathological processes can be 4: Wallerian degeneration, axonal degeneration, primary neuronal degeneration also, and segmental demyelination. But remember, diabetes can have all pathological processes: metabolic, microcirculatory, compressive, autoimmune etiologies, all can give you a great spectrum of DPN. So you can have a variety. It can be metabolic pure, like diabetic neuropathic cachexia, or treatment-induced neuropathy, that will be purely metabolic. You can have ischemic or vascular, that is your plexopathy, radiculoplexopathy, or Burns-Garland syndrome. And mix of them is typical of DSPN. Typical, most commonly, it is axonal degeneration. It is a dying back phenomena, length-dependent phenomena, starts from your toes, feet, ascends upward, then involves your hands. So it's a stocking and glove. Don't talk about glove and stocking. It is a stocking and glove phenomena that is typical of axonal degeneration, typical of DSPN. Myelin sheaths breaks down along the axon in a process that starts most distal part of the nerve fiber, progresses towards the nerve cell body. You can see here the difference between demyelination and axon. I think axonopathy all is alluded to all of you. But only difference is that in axonal degeneration, you can see the cell body has also gone down. So there is very, very limited chance of any reversal, any remission, or any improvement, very, very limited chance in axonal degeneration, whereas patchy phenomena like demyelination, you can get definite amount of improvement. Again, very important to remember, there are two types of nerve fiber, myelinated and non-myelinated, but they are also depending upon their size and also their conduction velocity. You can have thinly myelinated or unmyelinated nerve fiber taking care of your autonomic nervous system, temperature and pain perception, and vibration perception threshold. Muscle control is by A alpha and A beta fiber, which are large fiber, and they are myelinated thick fibers. Now makes a difference. Very fast nerve conduction velocity with the large fibers, so they will be picked up by NCV. Nerve conduction velocity will be picking up only these fibers, whereas small fiber neuropathy will not be picked up by NCV. So don't send your each and every patient of DSPN to nerve conduction studies. It will not give you any benefit. Etiopathogenesis, it is nutrient overload. Remember one thing: glucose overload, lipotoxicity associated with vasculopathy, ultimately leading to one thing: mitochondrial degeneration, mitochondrial damage. It is a mitochondriopathy. All these things basically culminating into mitochondriopathy. And why I say it's a mitochondriopathy, because mitochondria, healthy mitochondria, are formed only in the cell body. That has to be trafficked down up to your toes. So if there is any discrepancy in between this traffic, you will find the decreased power supply to the toes, to the nerve fibers, and that leads to neuropathy. Classification everybody I think knows: symmetrical and focal and multifocal neuropathy that can all coexist. You can find DSPN with the carpal tunnel syndrome. You can have DSPN with tarsal tunnel syndrome. You can have amyotrophy, diabetic amyotrophy with DSPN. So everything can be there in a single patient, because it's a huge spectrum moving from metabolic to vascular involvement and a combination of metabolic and vascular involvement. So all these spectrum can be there. Now very important, we don't talk about autonomic neuropathy. The patient can die of this autonomic neuropathy. Earliest to present is autonomic neuropathy. Ask about these symptoms of autonomic neuropathy. I will let you know how you can ask. And always suspect it. Always suspect it that this is definitely there. Even 20% of your type 2 diabetic patient right at the time of diagnosis will have 10 to 20% will be having autonomic neuropathy in the form of erectile dysfunction, is the form of gastroparesis, in the form of gustatory sweating, in the form of cracked heels. Okay, so remember this is very, very important because this can lead to falls, fractures, but it can also lead to QTC prolongation. And these patients can die off even at the OT table. And we have lost patients of podiatrists doing surgeries without going for autonomic neuropathy testing. And one simple bedside tool which I always say to my podiatry colleague, look at the pulse. Palpate the pulse. Take deep breath. Say it decreases. The pulse rate decrease. Significant amount of pulse rate should decrease, but deep inspiration. And if it improves with the expiration. So that patient has got intact autonomic nervous system. Fine. That one thing is all. Blood pressure, always take blood pressure supine, sitting and standing. This is mandatory for a diabetic patient. So typical presentation will be distal symmetrical peripheral neuropathy, various signs and symptoms depending upon the picking up the neuropathy, maybe small fiber and large fiber. I am going to talk about that also. But signs and symptoms, they progress in same manner. So how to go? Stepwise approach, ask for the symptom, go for certain tests, and if there is any discrepancy, then your neurology colleague should be your assisting. So signs and symptoms should go like this. Both should be in hand and hand. Small fiber neuropathy, patient will speak of lot of symptom, but no signs. Paradoxically insensate feet, but continuously paining. Say for few months, patient continue to have all symptoms with various vernacular language. पैर जलते हैं, ये होता है, वो होता है, सो भी नहीं पाता, depression हो रहा है, anxieties. All these things can be due to small fiber neuropathy, and you send your patient for NCV. NCV will be absolutely normal. Deep tendon reflex is absolutely normal. Monofilament normal. BPT normal. So it's a patient is hysterical? No. Patient has got small fiber neuropathy, and after 3-4 months, patient is not complaining anything. So will you be happy? No. It has progressed. It has progressed to insensate feet. Now you should check for all those intrinsic feet, muscles and everything. You will find there are differences now. And now NCV will be positive maybe. So large fiber neuropathy, you will have impaired vibration perception. Pain will be deep, gnawing, bursting type of pain. Numbness will be there. These are negative symptoms. And wasting and small muscle of hands and feet will be now there. Weakness will be there, patient will have more falls, fracture and chances of development of Charcot feet, and we call it intrinsic minus. When there is, you can see that in between the tendons, the muscles are now getting atrophied. So large fiber, small fiber. So it can be most of the time it is a combination, just 2 minutes more, because it's more of clinical. Huh? So consideration for developing differential diagnosis, even when the diagnosis is very clear. Type 2 diabetic patient, long duration diabetes, uncontrolled diabetes, having all symptoms, but search for all these things that can be there. B12 deficiency, then there can be pure thiamine deficiency, and these are treatable. Thyroid, hypothyroid, very commonly associated. Drug induced, very commonly associated. Then heavy metal toxicity can also be there. Signs for peripheral neuropathy, dystrophic nails, callus, bunion, or pre-ulcerative lesions. These are all pre-ulcerative lesions. Clawed toes, hammer toes, and dry and cracked heels. Even when you can find the absolutely normal looking feet. But if you have got prominent veins on the dorsum of your feet, suspect autonomic neuropathy. Because there is more shunting of blood from arterial side to venous side. Even you can check the blood, this oxygen saturation, this will be just nearly equal to the arterial oxygen saturation. This is a sign, Jadwal sign, that was given to this prominent veins on the dorsum. In between the toenails, in between the toes, you can find maceration, and also, unluckily, your patient may be having some callus formation or any ulceration. Always look for the dorsiflexor strength when you are looking at the feet. Dorsiflexor strength, plantar flexor strength, then supinate or inverter and everter strength also. This one simple test you can do. Extensor hallucis longus power, EHL power test. Simply asking patient to dorsiflex the extensor, this great toe, and you can see the tendon becoming prominent and the force. And if that there is a discrepancy, definitely this indicates your patient has got motor neuropathy and highly vulnerable for callus formation. Look for the limited joint mobility. Roughly it should be 50 degree when the patient is non-weight bearing, but once patient is weight bearing, it should be 15 degree. Also at the ankle joint, dorsiflexor. These are the simple tools, hardly costing not more than 1,000 rupees. Monofilaments, your tuning fork, 120 Hz tuning fork, your pin pricks sensation with Watermer wheel, and also your this knee jerk hammer. And this tool is known as tip thumb. For that can be many pharmaceutical companies, they are giving it free of cost. But only thing, you have to do it. You have to learn it. You have to do it. So in OPD, you have to check for small fiber. You have to check for large fiber neuropathy. And for monofilament test, this is the test to do. Very sensitive, very specific for loss of protective sensation. Even single site absent will tell you that your patient has got significant amount of loss of protective sensation, and that relates to chances of development of amputation, ulceration. Similarly, this is, if you don't have vibration, this monofilament, you can do it Ipswich test, touching and going, asking the patient to just for few seconds, less than 2 seconds, ask the patient ki kuch feel hota hai ki nahi hota, kuch feel hota hai ki nahi hota, just touching the toes with your index finger. This is 120 Hz tuning fork, but age-related changes can be happening. I think this bedside clinic is in more in those who are like me in practice, but I think in medical colleges, these are the important things which you are doing, but don't forget once you go out from this medical college. Bioseisometer, very handy tool to be have in your clinics. Importantly, if the vibration perception is above 15 millivolt, mildly impaired. If it is above 25 millivolt, moderate but 7-fold increased risk of amputation. 40 millivolt above, 33-fold increased risk of amputation. So very sensitive, semi-quantitative test, but tell you how much amount. You can give the report to the patient. This is vibra tape, that is also very handy, that can be taken for the vibration perception threshold. This is new technology, new instrument. This is tip thumb, this is ankle jerk. So pain diagnosis, simply you can use your toothpicks and that can be applied on the just before the toenails on the dorsum. Sarcopenia assessment is very, very important. I am just saying this is because now you have got a flurry of drugs to decrease body weight. Select trial showed semaglutide given in patient for CVOT in patient with obese and overweight. If the age group tackled is above 50, 2-year-old females being taken, that subgroup showed significant amount of osteoporosis. Even the risk of falls and fractures increased. So sarcopenia can directly correlated with increased amount of decreased bone mineral density and more falls and fractures. So GLP-1 increasing bone mineral density or are safe for bones, still we have to answer lot many things. Now, when to refer? I think this is the last slide I'm going to. Pronounced asymmetry in the neurological deficit. If there is pronounced asymmetry, you have to refer your patient for neurological assessment. Predominantly motor deficit, mononeuropathy or a cranial nerve, always go with a neurological opinion, otherwise you will be missing something like ICSOL or something. Rapid development and progression of symptom, always ask for the help. Progression of neuropathy despite optimal glycemic control and symptom arising in the upper limb first. If your thumb is involved first, then your feet, you are doing something different. It is not purely DSPN. Proximal weakness, maybe AIDP, may I see ADP. Significant sensory ataxia, this is something different, but even in diabetic, you can have pseudo-diabetic type of neuropathy also. Prominent or severe autonomic symptom, it is not purely DSPN. Family history of non-diabetic neuropathy, it's something different. Pain that is difficult to manage and limiting the patient lifestyle, this is not purely due to DSPN. It can have associated factor. Nerve conduction, only different between demyelination and axonopathy, everything knows. How to treat? There is no disease modifying agent. No disease. Only thing, you have got anticonvulsant, you have got ECA, and you have got SNRI, you have to combine them together. Combination is the best. Go with the lowest dose. You can use non-pharmacological therapies also, and for that acupressure, acupuncture and FRAMs and all TENS are all indicated. So combining together only target about 30 to 50% of the symptomatological relief. Don't try to go up to 100% relief. Your patient will have lot of toxicity, lot of side effect, and patient will come back to you with various complications. So don't try to achieve the dosage which has been given in the books for Western population. They are not for us. Try to use homeopathic doses of pregabalin, gabapentin, combine them with TCA, oblique SNRI. Don't try to make them three together. Thank you.
Very good, excellent summarization of the topic. I think proper history and proper clinical examination, these are two main parts. If they are done properly, 60 to 70% diagnosis is made. So bedside teaching, which is still prevalent in many colleges,
yes,
is doing good.
But getting extinct now.
That is good. So with this topic, I ask the audience any question. So no question. Thank you, sir.
Thank you. Very good. Thank you. Thank you.
Thank you so much, sir, for that impactful and thought-provoking session. I now request our chairpersons to kindly felicitate our speaker, Dr. Sandeep Suri, sir. Next, I would like to request Dr. Namrata ma'am to felicitate our chairperson, Dr. S.P. Gupta, sir. And with that enlightening session, we come to the end of what has been an extraordinary academic journey, the 6th Annual Conference of Cardiodiabetic Society 2025. These 3 days have been much more than a conference. They have been a celebration of continuous learning, mentorship, and academic excellence. Each talk, each discussion has added a new dimension to our understanding of holistic patient care. Now, we will proceed to the valedictory function of this conference. I would now like to request Professor Ravikant sir, Organizing Chairperson, Cardiodiabetic Society Conference 2025, Dr. Mukesh Bhairava sir, Organizing Co-Chairperson, and Dr. Anirudh Mukherjee sir, Organizing Secretary, to come to the dais. We begin with the paper presentation awards. I request Professor Ravikant sir to kindly felicitate the winners. Second place goes to Dr. Ashish, Junior Resident, Department of Biochemistry, Aiims Rishikesh. First place goes to Dr. Kushbu, Department of Biochemistry. Next, we move to the poster presentation awards. I request Dr. Mukesh Bhairava sir to kindly present the awards to the winners. Second place goes to Dr. Asif, Junior Resident, Department of Emergency Medicine, Aiims Rishikesh. First place goes to Dr. Shaurya, Junior Resident, General Medicine, Aiims Rishikesh. We now come to the case presentation awards. I request Dr. Anirudh Mukherjee sir to kindly felicitate the winners. Third place is shared by Dr. Pavan, Department of Emergency Medicine, Aiims Rishikesh, and Dr. Shweta, Department of General Medicine, Aiims Bathinda. Second place shared by Dr. Nitish, Junior Resident, Department of General Medicine, Aiims Bathinda, and Dr. Om Sharma, General Medicine, Aiims Rishikesh. First place goes to Dr. Anup, Junior Resident, General Medicine, Aiims Raebareli. And now, one of the most exciting highlights of the conference, the Cardiodiabetes PG quiz. I request Professor Ravikant sir to kindly present the awards to the winners. Third place goes to Dr. Gagan and Dr. Manoj, Junior Residents in Department of Medicine, Aiims Rishikesh. Second place goes to Dr. Anushka and Dr. Anika, Junior Resident, General Medicine Department, Aiims Rishikesh. First place goes to Dr. Bikki and Dr. Krishna, Junior Residents, General Medicine Department, Aiims Rishikesh. Congratulations once again to all our winners and participants. Your passion and effort have made this conference truly vibrant. Now, I would like to call upon Dr. Anirudh Mukherjee sir, Organizing Secretary of the conference, to share few words on this occasion.
It gives me immense pleasure and immense sense of happiness to address all of you at this closing hour of this wonderful academic feast, which offered so many varieties of buffets from different parts of the medical field that I feel fully satiated to the utmost level of satisfaction right now. I hope all of your academic hunger has been satisfied. If yes, give the event a round of applause, please. I really thank all the faculty members who took their time out from their busy schedule and they graced this event for the last couple of days. And last but not the least, and the most important, Professor Ravikant, who is the leader, who has this vision of analyzing what is going to happen tomorrow and implementing it today. I want to give a big round of applause for sir. And, and, and Dr. Mukesh Bharwa, who perfectly compliments him in every step he takes and has always been guiding me throughout. I was a faculty working here earlier also, and I've been under their guidance all throughout. I still seek for guidance from them. I thank all the residents of Aiims Rishikesh who have done a commendable task. I mean, hats off to you. I wish even I can develop such residents in the future at Aiims Raebareli. I mean, the way you work in coordination, Anish was in constant touch with me regarding every event. I mean, I could feel that I am not at Aiims Raebareli, I am physically here at Aiims Rishikesh because of him. I mean, a round of applause for all the residents. For all the residents, I don't remember the name of everyone. I'm so sorry. I would have loved to take all of yours name. And I really thank the IT team here. The IT team has done a wonderful job. I mean, the way, the precision of your work is absolutely evident, and people will see when we share the photographs. I mean, they have clicked wonderful pictures. I also thank the caterers who have provided a delicious meal to everybody who has attended here. And I thank all the other support staff. If I am forgetting anybody, I am so sorry, but I am thankful to everybody. A round of applause for Cardiodiabetic Society 6th Annual Conference. Thanks a lot.
Thank you, sir, for your kind words. Now, I would like to call upon Dr. Mukesh Bhairava, sir, organizing co-chairperson, to speak few words on this occasion.
Professor Ravikant, Head of Department, Dr. Anirudh Mukherjee, Organizing Chairman, Organizing Secretary, all the delegates, all the speakers, all the chairpersons. The organizing of a conference is like organizing or doing a marriage. Until it happens, you always having some fear. What happened tomorrow, what happened the next day. So today I am very happy that we organized. Hopefully you enjoy very well. All the scientific session was very specific to the points of Cardio and Diabetic Society, the motto of our society. The future of our society, we are trying to expand the society to all over the country. Then we go for the abroad. And we planning to start the curriculums, activities, and some fellowship courses in our society. So I like to thank all the speakers, delegates, and I will not take any much time because you all are hungry. Thank you so much.
Thank you, sir. Now, I would like to call upon Professor Ravikant, sir, organizing chairperson, for the concluding remarks on this occasion.
Thank you so very much to all of you for staying with us for last almost 3 days. I would like to share the academic activity has been granted with 12 credit hours by Uttarakhand Medical Council, which is the, which speaks for yourself. I'll share a very, remarkable experience for my life for 2 minutes only. Because we were, organizing so many conferences, and my wife used to come to some of the conferences. Then she said, can I organize a conference? I said, yes, why not? You can also do it. She is heading the Department of Dermatology. Okay, ठीक है, उसने काम start किया. Then she started organizing conference. She started asking me how to do that. I don't know. When how to take credit hours, I don't know. How to, who knows it? Bala knows it. Because I tell Bala, he does everything for me. So for last 1 year, she was fed up with me. She said, you organize, I know. but I now know sure that you have no idea of how to organize the conference. So that talks about the credibility, dependability, sustainability, and the strength of my residents. A big round of applause to all of them. The residents who are trained here, they are not only intelligent, they are skillful, they are having some other ingredients which probably no other medical colleges are offering. And this is a later learning. I am proud of Dr. Anisha, who has been taking this momentum from Dr. Bala, and he is successful under the guidance of Dr. Bala. He has done a wonderful job. Dr. Anushka, Dr. Dheeraj, Dr. Yudanshu, Om, Mithilesh Ankyan, Kashish, Mudita, Gagan, Komal, Sangappa, Sheetal, and Amit. All of them have been jewels throughout the journey of this conference since its inception and execution, and perfectly they have done what is expected out of them. And my supporting staff, Vineet, Joyal, Rajesh, Gopal, Kalpana, and Vijay. They have been cornerstone for the conference. They have been remaining there behind the screen, but their contribution is immense. I am so proud of them. And our diabetes educator, who is the main pillar for all such conferences, he knows what to do, how to do. We have a dedicated diabetes educator through which we are doing a lot of diabetes education. So they are the pillars for the conference, not me myself. At the same time, I take the opportunity to thank Dr. Mukesh, who has been, a constant source of energy and execution to everything from minute to major, conferences. Dr. Anirudh, who has been distantly monitoring the entire project from Aiims Rishikesh and executing it very nicely. So I am so thankful to all of you at this moment, and I wish we flourish more, we go beyond obstacles, and more academic activities are to be started. So with this, I thank you all very much, and the sincere thanks to pharma colleagues who have sponsored the program well, because their support is immense. At the end of the day, all these activities require unsupported grant from the pharma companies who have been with us throughout the journey, and we hope so to flourish more and more. I thank you all very much and hope so to meet again in near future. Thank you very much.
Thank you, sir. Now, I request Dr. Prakash, sir, to deliver the vote of thanks.
Good afternoon, everyone. Distinguished faculty, special guest, respected Ravikant sir, organizing chairperson, Mukesh sir, co-organizing chairperson, Anirudh Mukherjee sir, organizing secretary, Seema ma'am, Namrata ma'am, and all the guest faculty coming from Uttarakhand and other Indian from different parts of India, and all the JR, SR members of media, pharma companies, dear friends. Good afternoon to all, one and all. As we draw the curtains on this incredibly insightful and productive 6th annual Cardiodiabetic conference with focus on recent updates, it's my privilege and honor to stand before you to express our profound gratitude to everyone who made this event a resounding success. First and foremost, we owe a tremendous debt of gratitude to Ravikant sir, our organizing chairperson, your vision for this conference and your unwavering leadership and your meticulous attention to detail have been the back rock upon which the entire event was built. Your wisdom and your encouragement stayed with us through every challenge. For that we are externally grateful, sir. Our sincere thanks also go to Mukesh Barwa sir, our co-organizing chairperson. Sir, your steadfast support, strategic guidance, and relentless effort, which we have seen in last 3 days, in coordinating this merit aspect of this conference, were invaluable. You are the pillar of strength that ensured everything ran like a well-oiled machine. This event would not have been moved from an idea to reality without the dynamic and tireless work of Dr. Anirudh Mukherjee sir, our organizing secretary. You are the engine of our organizing committee who can make, and we cannot thank you for enough for your dedication, sir. We are deeply indebted to our eminent faculty from Aims, from other Indian different faculty coming from Uttarakhand and other states. You graciously shared your invaluable clinical experience, your profound knowledge, which enriched our understanding and sparked thought-provoking discussion. Thanks you for traveling to be with us and for elevating the academic standard of this conference. I also want to thank our esteemed delegates and participants. The very heart of this conference. Thank you for coming. Your active participation, engaging questions, and intellectual have currently created vibrant learning atmosphere in this conference. I also want to especially thanks to all the volunteers and organizing team, which include Dr. Bala, Dr. Vinay, Dr. Dheeraj, Dr. Anushka, Dr. Anish, Dr. Om, Dr. Kashish, without whom this conference would have been a success. Your behind the scene work from registration desks to technical support did not go unnoticed. This success is as much as yours as everyone else. I special note of appreciation to our sponsors and pharma companies and catering staff for making this conference a great success. Finally, to each and every one of you who present here, thank you for your time and for being a part of this collaborative journey. As we depart, let's carry forward the knowledge we have gained, the connections we have forged, and renewed our commitment to improving patient care in this intertwined field of cardiology and diabetology. Thank you all for all once again for making this 6th annual Cardiodiabetic conference a memorable one and impactful. Have a safe journey, and we are looking forward and welcome you again next year. Thank you.
Thank you, sir. With that, we officially conclude the Cardiodiabetic Society Conference 2025. Thank you all for making it a memorable success. Now, may I request all the faculty for a group photo. And followed by residents also.